Professor and HOD Pathology, JMN Medical College, Chakda, and Professor Dr. Ranbir Paul Sir, Professor, Department of Preventive and Social Medicine. Thank you. Now, I would like to invite our first speaker, Dr. Manoj Kumar, on stage to present the topic TMS, a new radiological classification for the risk assessment of FESS, a retrospective observational study. Thank you.
हाँ खोलते हैं मैम.
To do this one slide. Good morning to all of you. Today I'm going to present a paper on TMS, that is Thailand, Malaysia, Singapore, a new radiological classification for the risk assessment of FAS, a retrospective observational study. As all of you know that for paranasal sinusitis, FAS is the common surgery nowadays, and it has some complications like CSF leak, orbital injury, or hemorrhage. So understanding the CTPNS anatomy is very essential before going to the surgery. And the frequency of these variations may differ in different populations, but one thing is fixed, that there's orbital floor, which is constant in relative to the skull posteriorly. So Quiros, it is old classification given in 1962, and TMS is the classification given by Abdullah et al. In 2020, and it's a new practical radiological classification that completes the Quiros classification to assess the anatomical risk of anterior skull base injury. The aims of this study is to design to assess the variation of the ethmoid roof and orbital floor through Quiros and TMS. Now, we have taken the 50 patients in the last 5 months from the database of the Department of Radiodiagnosis, MGM Kishanganj. Inclusion criteria and exclusion criteria were being very simple, that it should be completely developed VNS and showing the crista galli of ethmoidal roof and nasal fossa with no gender consideration. And if there is any surgery, sinus surgery or maxillofacial trauma, that were excluded. Images, all CTPNS scans were, coronal sections were used for the measurements. Now Quiros we have taken the depth of the cribriform plate as measured the vertical height. Like in this section, this is the Quiros classification as cribriform plate and the height of the crista galli. That is measured on each side. And orbital floor, this is the base of the TMS classification given by Abdullah et al. That orbital floor is taken at the maximum height of the maxillary sinus, and the medial one is the height of the orbital floor to cribriform plate, and the lateral one is height of the orbital floor to the ethmoidal roof. And the risk, according to the TMS classification, type 1 is low risk when both the height, orbital floor and cribriform plate, orbital floor and ethmoid roof is more than 10 mm. And moderate risk when either of the height of the orbital floor to cribriform plate or ethmoidal roof is less than 10 mm. And type 3 is when both are less than the 10 mm. So result as the distribution of the Kiros 2 and TMS type 1 is maximum, 86 and 88% in our study. So conclusion is that the most prevalent variation of ethmoid roof are Kiros type 2 and TMS type 1. Although prevalence of the high risk types, that is Kiros type 3 and TMS type 3 was very low. But pre-operative assessment is very essential before going to surgery, because there is an interesting difference between those TMS and Kiros, that Kiros type 1, which is not so much risky, can be TMS type 3. So it is essential and prerequisite before going to the surgery. And there are different heights of the ethmoid roof in relation to orbital floor, and these are not reflected by Kiros classification. Therefore, TMS, when used together with the Kiros classification, provides additional information to reduce the risk of skull base injury. It serves an additional assessment besides Kiros classification. These are my references.
Hello. All patients are adult patients.
All patients were adult patients.
Oh, and any gender bias you found, difference of gender bias in this measurement? Have you found any gender difference of this measurement? Telling Mike.
We have taken the patient who have fully developed PNS, whether the age, it is almost more than 15 years of age.
No, what I mean is there are male patients and female patients you have taken.
Yeah.
How many male and how many female you took in this sample of 50?
32 male patients were there out of 50 patients.
Out of this, have you found any difference of this measurement?
No. Orbital flow difference is in the Kiros classification, where the cribriform plate size is small in the females. But in TMS classification, orbital floor is almost fixed.
Main problem is you have shown only normal, these are all normal CT scan, no?
These are normal.
So will there be any change if the sinuses are pathological?
Definitely, we have not gone into the pathological.
You have not indicated that. Whether suppose pathological, there may be erosion of the bone and the height may diminish and the space that you are thinking of in Kiros type 3, that may also change. So classification may change based on when these are infected.
But sir, in that there are also almost in other studies that pathological conditions, like I have taken the pathological condition like sinusitis, like other things, polypoid, but not the fractures. These are the studies in the sinusitis. They have operated these patients. ENT surgeons have operated these patients. And the orbital floor is fixed.
You started your presentation with injuries, hai na? You have mentioned that when there will be injuries to the orbital floor.
We have excluded the injuries to the orbital floor. We have excluded.
Okay.
Any cases of DNS?
Yes, DNS is a common finding. But it does not differ the findings of TMS or Kiros. Because Kiros, we have taken the cribriform plate to the crista galli, and in TMS, we are taking the orbital floor at the maximum maxillary sinus.
You mentioned, I think, Kiros type 1 and TMS type 3 are sometimes...
Kiros type 1 is most common. Kiros type 2 is most common.
No. The same case may be Kiros type 1 and TMS type 3.
TMS fulfills the Kiros as...
So one is low risk and the other is high risk. One is low risk, the other is high risk. How can you...
That's why this TMS classification given by Abdullah et al. In 2020, it fulfills the Kiros. It doesn't replace the Kiros. It fulfills the Kiros that we have very cautious. If it is saying only type 1, type 2 Kiros is there and TMS type 3 is there, that we have to be very careful. Because then forceps will injure the cribriform plate and all this.
So why not go for the newer classification only? if the previous classification is
So
causing this
both
discrepancy?
bases different. One is taking cribriform plate, other is taking orbital flow to the cribriform plate. So both the studies, if you are doing both the studies, then it is very good for the ENT surgeon to assess the things.
Okay, thank you.
Thank you.
Now, I would like to invite our next speaker, Dr. Sheikh Faizan Ahmed, to present the topic Chronic Pancreatitis Diagnosis, a comprehensive study of ultrasonography and CT imaging techniques.
मेल पे है क्या? मेल पे मिलेगा? हाँ उस पे है। हाँ मैंने दिया है। अभी नहीं दिया था, उस दिन मैंने सबमिट किया था। हाँ इन्वेस्टिकॉन।
तो लैपटॉप बदल देते हैं हम, सबका फाइल ट्रांसफर जाएगा। मैं कल भी वही बोल रहा था सर, बाद में पता चला तो पेंडेंट।
Good morning, all of you. My topic is chronic pancreatitis diagnosis, a comprehensive study of ultrasonography and CT imaging techniques, which I have done under the guidance of Dr. Ankit Patel and Dr. Preeti Kapoor. Chronic pancreatitis is a long-standing inflammation of the pancreas that leads to permanent damage and impairment of its exocrine and endocrine functions. This condition can cause recurrent episodes of abdominal pain, malabsorption, and diabetes mellitus, significantly impacting the patient's quality of life. Traditionally, the diagnosis of chronic pancreatitis has relied on clinical symptoms, laboratory tests, and imaging studies. However, clinical presentation alone can be non-specific and overlap with other gastrointestinal disorders. Biochemical tests, including serum amylase, lipase levels, are often unremarkable in chronic pancreatitis, especially in advanced stages when the pancreas is severely damaged. Radiological imaging plays a pivotal role in diagnosing chronic pancreatitis. Conventional radiographic methods such as plain X-ray can detect pancreatic calcifications but are limited in sensitivity and specificity. Ultrasound is a non-invasive, cost-effective and readily available imaging techniques that provides real-time visualization of the pancreas. It is particularly useful in detecting pancreatic ductal changes, calcification and atrophy associated with chronic pancreatitis. However, ultrasonography has limitations, including difficulty in visualizing the pancreas in obese patients or those with significant bowel gases, which can obscure the pancreatic tissue. CT, on the other hand, offers detailed cross-sectional images of the pancreas and surrounding structures. It is highly sensitive in detecting pancreatic calcification, ductal dilatation, and parenchymal changes, such as atrophy and fibrosis. My study aims to evaluate and compare the effectiveness of ultrasonography and CT in diagnosing chronic pancreatitis. By analyzing the strengths and limitation of each modality, we seek to determine their respective roles in clinical practice and provide recommendation for their optimal use in managing patients. This study was conducted over a period of 18 months from July 23 to January 25 in our department. inclusion criteria were patient presenting with clinical symptoms indicative of chronic pancreatitis, patients with elevated pancreatic enzymes levels, patient who have consented to undergo this study. Exclusion criteria were pregnant female, patients who refused to undergo the imaging procedures, patient with known contraindication to contrast media. Methods were the ultrasonography initial evaluation was performed using a Samsung HS40 ultrasound machine with a curvilinear probe or 2 to 5 megahertz frequency. Pancreas was assessed for size, echogenicity, duct dilatation, calcification, and parenchymal changes. Special attention was given to identifying atrophy and fibrosis. CT was conducted using a Philips MX16 slice CT scanner. Data were collected on, and the statistical analysis was done using SPSS 26 windows. Results were the chronic pancreatitis were seen in mostly in males. Out of 10 patients, 7 were male, and the age is very less than 30 years. On etiology, we found idiopathic was the most common etiology, followed by alcoholism, autoimmune, hyperlipidemia. On ultrasound, we have found that contracted pancreas were found in 60% of the cases, with normal size of the pancreas in 40% of the cases. Hyperechoic pancreas was seen in 40% of the cases. Heterogeneous echo texture was seen in 30% of the cases, but the most common finding was duct dilatation, which was seen in 90% of the cases, and calcification, which was seen in 80% of the cases. On CT, again, we have most commonly we found duct dilatation in 90% of the cases and calcification in 90% of the cases. On comparison with USG and CT, we found that contracted pancreas was seen in 60% of the cases. Normal size of the pancreas was seen in 40% of the cases. Duct dilatation in 90% of the cases. Calcification in 90% of the cases on CT, while 80% of the cases on USG. These were the images where we find pancreatic calcification scattered throughout the parenchyma. In both ultrasound and CT are essential in diagnosing chronic pancreatitis, each offering unique advantages. Ultrasonography is valuable for initial assessment, while CT provides detailed and comprehensive evaluation, particularly in detecting calcification and structural changes. The complementary use of these imaging modalities enhances diagnostic accuracy and aids in effective management of chronic pancreatitis. Continued research and advancement in imaging techniques are necessary to improve diagnostic capability and understand the diverse etiological factors contributing to chronic pancreatitis.
So, you have only 10 cases in 18 months. Which institute is this?
Actually, acute I have done research on acute pancreatitis, but simultaneously.
Is this your thesis?
No. My thesis was on acute pancreatitis.
So why did you accept? Why did you consider studying this? This has been thousands of studies on this particular topic has been already done. What is unique? Why you are presenting here? What extra thing you are informing us?
So that we can.
But this has been this is being done for the last 30 years. Same study.
Yes, sir.
So what is unique in your study?
Many a times patient come to the emergency with abdominal pain and related pancreatitis related
that
symptoms.
is not the challenge. The challenge is to find out why idiopathic cases are happening. Can you tell us why idiopathic cases happen? Idiopathic pancreatitis happen? You said now 5 of the cases
yeah,
are
yeah.
idiopathic. Why? What are the usual, is there any congenital problem that can lead to this kind of problem?
Yes, genetic problem is there.
What genetic problem? You have not studied that.
No, sir.
Anyway.
In your study, we found that comparative table, USG finding and CT finding are
Almost,
same.
almost similar.
So why we go for CT? You could not explain. Because USG is very easy and cheap. Why you people who go for?
But detail anatomy and structure of the pancreas is not.
In your study, it was not found. That I'm telling.
Yes, sir.
You could not find anything difference between the two observation, two investigation. Okay, thank you.
Thank you, sir.
Thank you. Next, I would like to invite Dr. Anupama Sahu to present the topic, the histopathological spectrum of gastric biopsy in small-scale industrial workers attending tertiary care hospital, Kolkata.
Good morning, respected judges, delegates, and my dear colleagues. I am Dr. Anupama Sahu, first year pathology PGT, will be presenting paper on histopathological spectrum of gastric biopsy in small-scale industrial worker. Gastric disorders are commonly seen in clinical settings, and endoscopy allows direct visualization of such lesions. Histopathological examination of endoscopic biopsies is vital for early diagnosis of non-neoplastic and neoplastic conditions, out of which chronic inflammatory conditions are the most frequent gastric findings. Gastric cancer ranks 5th in incidence and 3rd in cancer-related deaths globally, with a 70% of case fatality rate. In India, it's the 4th most common cancer in males. Occupational exposure to chemicals in small-scale industries increases the risk of gastric mucosal changes and cancer. Despite this, there is paucity of literature focusing on the histopathology of gastric mucosal lesions in small-scale industrial workers. We attempted to bridge this knowledge gap by assessing gastric biopsies of small-scale industrial workers and their families and evaluating HP diagnosis with occupational exposures. By doing this, we hope to enhance early detection strategies and inform preventive measures for at-risk population. The objective of this study is to evaluate the HP spectrum of gastric biopsies in small-scale industrial workers and their families over multi-year period of time and corroborating the HP diagnosis with occupational exposure. A retrospective study was conducted in 101 patients over a period of 4.5 years in Department of Pathology in ESIC Joka. A case-based performer was developed and information was gathered directly or on telephonic communications. All the radical gastric resections and endoscopic gastric biopsy samples were taken. Biopsies with unremarkable histopathological features were excluded. This is the results. The most common findings of the study was gastritis, which was more common in females than in males, followed by the adenocarcinoma, which was more common in males than females. This is the spectrum with the industries, better explained in the better seen in this pie chart. The first graph is showing the association of non-neoplastic lesions in the occupational workers. It was the maximum association was found in agricultural workers and the people working in food industry. That was 19%, followed by the machine operator industry and the jute industries. In malignant, association of malignant lesions and the occupation, the maximum association was found in agriculture, followed by food industries, followed by the jute industries and steel industries. These are the photomicrographs, photomicrographs of the lesions. The first one is of chronic gastritis. The second one is of strongyloid stercolysis chronic gastritis. The third one is of benign lesion leiomyoma. The fourth one is of intestinal metaplasia. Here the first photomicrograph is of well-differentiated adenocarcinoma. The second one is of signet cell carcinoma. The third one is of poorly differentiated carcinoma. The fourth one is of gastric polyp. To conclude, our results showed that there were malignancy rates more among small-scale workers, which was consistent with the findings of the paper published in 2020 by Yoshinaga. These were my references. Thank you.
Usually, we associate lung disease as part of the occupational exposure. And GI involvement is usually not after lung, kidney, and genitourinary tract is the next most. Why would you think of gastric involvement as due to occupational exposure?
So actually, gastric carcinoma.
Going along with that question is, have you compared your findings with the other population, those who are not associated with the small-scale industry?
As first question I'd like to answer, that gastric carcinoma is like one of the most common. In males, it's for the fourth most cancer, and there is like high mortality rate. And there was like, as you said, there are very few studies and few literature there which shows. So I thought we have some scope. And here also we found some associations. It was there. And sir, can you repeat your
second is, you're saying that it is more common in workers in
yes, sir.
A small-scale industry. So have you compared your findings with the other population who are not working with small-scale industry?
So there are people who doesn't belong to small-scale worker. There are like normal office clerk works.
No, in your study, have you then you have not shown the data, that data?
No, sir. They are just included in the others part of, so we have not compared.
So that conclusion that it is found more, that is not correct then?
No, sir. It is in the spectrum of our data, which we have collected. So.
See, you said this is because of occupational exposure. This was a retrospective study?
Yes, sir.
So you went back to these patients and
yes, sir,
you asked whether they had an occupational exposure?
So actually we collected we have the system where we have all the details of the patients. So the recent, this year's data was collected simultaneously, and the previous data, I collected the phone numbers, called them up and directly.
Yes, now one thing is, in this part of this gastric biopsies, this was my thesis topic, that's the reason I'm asking. So this part of the country, eastern region, has a very strong correlation with Helicobacter pylori. How did you exclude that confounding factor?
So
because how do you not know that these lesions are because of Helicobacter pylori?
So it could be. So we have nowhere, the thing is we have not excluded that part.
Because that is a very important factor.
Yes,
you cannot say that these lesions are not due to because they can be because of Helicobacter pylori, not because of occupational exposure.
Yes, sir. Actually the thing is we have included all the inflammatory conditions in the gastritis. So we have not taken that aspect, like it all comes under inflammatory conditions.
Yes, so I think that you should be considering when you are doing further research in this area.
Yes,
I have one question.
yes, sir.
it is commonly believed that tobacco consumption, particular chewable tobacco, that is smokeless tobacco, is one of the important cause of oropharyngeal cancer in the whole world,
Yes, sir.
including India.
Yes, sir.
Have you ever tried to explore those who had, you have found that highest number of in agriculture, and next is those who are industry in cooking. So have you found any exposure to chewable tobacco or smokeless tobacco?
So
Okay,
that
I
is-
think you can extend your study for
Yes,
that.
sir.
You
I
can ask
show-
them
Yes,
with this
sir.
type of question.
Yes, sir. I can show.
Some problem in your basic data also. You go back, do you think that steel industry is a small scale industry? You have shown steel.
So actually the workers.
There is no actuality. You tell me whether you studied or not. You are presenting something, no? This is a new data that you are saying there is correlation between professional hazard, etc. In that case, how jute industry, iron industry, this cannot be considered as small scale. And how soil and food. No, there is no parity in. There is no parity. You are mining and quarrying stone gravel, house oil, coke, and then jute industry and iron industry. How these are correlated with each other?
Sir, actually
Means
these are not.
you are superimposing your notion, your idea, or actual study.
So, we called up the patients and we are trying to just set the, if they are working in a small, so there are like small shops also, they melt the iron and they are not, like they do iron work, so they melt the iron ores and they make. Sir? Yes, sir. So, so 12.
Industry, jute industry, where only 10 workers is working. What is this?
In villages, they art. Thank you, sir. Thank you, sir.
Now, I would like to invite our next speaker, Dr. Pushkal Prabhat, to present the topic Microbiological Assessment of Drinking Water Sources in Rural India, a cross-sectional study from selected villages of Bihar.
Good morning, sir, ma'am. I am going to present paper on topic microbiological assessment. Good morning, sir, ma'am. I am going to present paper on a topic microbiological assessment of drinking water source in rural India, a cross-sectional study from selected villages of Bihar, that is West Champaran. Background. Access to microbiologically safe drinking water remains a persistent public health challenge in rural Bihar. Contaminated water is a major contributor to gastrointestinal infections and other waterborne diseases, especially in areas with poor sanitation and inadequate water treatment. Objective. This study aimed to evaluate the microbiological quality of drinking water from various sources in selected rural villages of Bihar and determine the potential health risks associated with microbial contamination. Methodology. A total 250 water samples were collected from hand pumps, open wells, tube wells, and stored household drinking containers across 15 rural villages in West and East Champaran district. Standard microbiological method including most probable number MPN technique were used to detect the total coliform, fecal coliform and Escherichia coli. Observational data and household interviews were also conducted to assess water handling and storage practices. Result: out of 250 samples, 190, that is 76%, were positive for coliforms and 138, that is 55%, for E. coli, indicating fecal contamination. The highest contamination was observed in samples from stored household water and open wells. Villages and poor sanitation facilities and improper water storage practices showed significantly higher level of contamination. A correlation was observed between the presence of E. coli and increased self-reported cases of diarrhea and gastrointestinal illness in children under 5 years. Conclusion: the findings revealed widespread microbial contamination in rural drinking water sources in Bihar, posing serious health risks. This underscores the urgent need for improved water sanitation infrastructure, public awareness program, and routine water quality monitoring in rural communities. Thank you.
I like to thank you for this study. This is a very, very good and yes, very good study, very relevant in our country. So you, how did you test these water samples? You had a portable laboratory or?
No, sir. In Betia, we have limited resources, and actually, I am the first PG of my college, 2022 batch. So there is very less resources. So we.
No, how did you collect the sample and tested it?
Yeah, we collected and we used MPN method, that is most probable unit. We use dilution method. We take a series of test tube, and we put our sample in diluted form. That is, if we drop 1 ml in first 5 test tube, then we diluted 10-fold, that is 0.1 ml. Then further we diluted 10 times, and we inoculate them for 24 to 48 hours and see color changes. This is statistical method. This is not very confirmatory. For confirmation for 100%, we have to use plating method. But somehow this is so some picture that is most up to 90% correct. And for
why you collected only 250 samples, or sample size calculation? Have you made any?
Sir, sample size calculation is taken consideration that 95% population of West Champaran considered, and error should be less than 5 to 10%, and we cover the maximum population, and we have idea that maximum population fall in this study. Our statistician helped me to.
No, what I asking? Another question, that you collected from 5 different sources.
Yes, sir.
Go to that plate.
Yes, sir.
Slide. Before that.
Yes, sir.
Hand pump, open well, tube well, stored housing, 4 places.
Yes, sir.
From 4 places, from each space, how many collection was done?
Sir, there is no specific data from where. If we go some home and they usage well, then we taken.
No. You told that from hand pump, how many samples was collected? That's asking. That should have been mentioned here.
Yes, sir. But here I am not mentioned that.
Okay. Because you found maximum in open well,
Yes, sir.
Stored housing water, that's what I'm thinking.
Yes, sir. Thank you, sir. Thank you.
Thank you. Next, I would like to invite Dr. Pragya to present the topic Study of the Spectrum of Bone Marrow Biopsy in Various Hematological Diseases in a Tertiary Care Hospital, Kolkata.
खुला हुआ है एक्चुअली, एक बार दीजिए, फाइल एक खुला हुआ है मैम, डिस्प्ले ये है मैम, कौन सा है मैम आपका, दीजिए मैम।
Good morning, respected judges, delegates, and my dear colleagues. Today, I, Dr. Pragya, a first-year pathology PGT, is going to present a paper on study of spectrum of bone marrow biopsy and various hematological diseases in a tertiary care hospital, Kolkata. Starting with the introduction part, bone marrow is the central hematopoietic organ producing red cells, white cells, and platelets. Abnormalities in any lineage may present as anemia, cytopenias, or leukocytosis. Bone marrow is a vital diagnostic tool along with the bone marrow aspiration, and since its first use in 1876, bone marrow examination remains essential for diagnosis, classification, and monitoring of hematological diseases. The objective of the paper was to study the spectrum of bone marrow biopsy findings in patients with various hematological disorders over a 3-year period, and to analyze the diagnostic utility of bone marrow trophine biopsies in identifying both benign and malignant hematological conditions. This was a retrospective observational study conducted in Department of Pathology and ESIC Medical College, Joka, over a period of 3 years, that is May 2022 to May 2025. 133 bone marrow trophine biopsies were taken, and the sampling technique used was purposive sampling. Biopsies was taken using Jamshidi needle from posterior superior iliac spine, which was later fixated and then decalcified, followed by tissue processing, paraffin embedding, and was sectioned at 4 to 5 micrometer thickness. H&E staining was done, and reticulin or special stains were done as indicated, which was evaluated for adequacy, cellularity, architecture, lineage, infiltrates, fibrosis, and stromal changes. Descriptive statistics was done using Microsoft Excel, which was expressed as frequencies, percentage, and ratios. The results showed the higher male preponderance with male is to female ratio of 1.71:1. Out of 133 cases, 84 were males and 49 were females. The age range was 13 to 84 years, with the mean age being 52.83 years. Pancytopenia was the most common indication, followed by plasma cell neoplasm under evaluation, later followed by other indications such as bicytopenia, thrombocytopenia, anemia under evaluation, response assessment, etc. This is a spectrum of various hematological disorders which was diagnosed. out of 133 cases, 126 cases were adequate, in which 94% of the cases were hematological disorders, followed by 6% of normocellular marrow. Acute leukemia was the most common hematological malignancy, which was followed by plasma cell neoplasm and myeloproliferative neoplasm. This is a photomicrograph of a HNE stained bone marrow biopsy slide, which showed a cluster of plasma cells infiltrating the marrow spaces, which was indicative of plasma cell neoplasm. Other photomicrographs showed increased number of blast cells with large nuclei, fine chromatin, and prominent nucleoli, and scant basophilic cytoplasm, which was consistent with acute leukemia. The first one showed a dwarf megakaryocyte with non-lobulated or bilobed nuclei and scant cytoplasm, which was suggestive of myeloproliferative neoplasm, such as CML or primary myelofibrosis. For the same patient, reticulin stain was advised, which showed moderate increase in reticulin fibers, forming a loosely interconnected network, which corresponding to the grade 2 fibrosis as per WHO grading system. To conclude, bone marrow examination is a key diagnostic tool for evaluating a wide range of hematological disorders. Acute leukemia was the most frequent diagnosis, followed by plasma cell neoplasm and MPN, indicating a predominance of malignant hematological disorders. Reticulin stain aided in assessing marrow fibrosis, highlighting its utility in conditions like MPN marrow stromal changes. 7 out of 133 biopsies were inadequate, underscoring the need of proper sampling technique and marrow adequacy assessment. Thank you.
Thank you. Very crisply presented paper. You could have, how many cases of marrow fibrosis did you get?
Sir, in MPN, 16.7% cases.
Marrow fibrosis, you mentioned that.
Sir, I have not mentioned it like.
So what is the purpose of, you mentioned the reticulin fibrosis, then if you're not looking for fibrosis or have not mentioned any case of fibrosis, what's the point of doing the trephine?
So myeloproliferative neoplasm included myelofibrosis.
But so that is a separate entity,
yes,
isn't
so
it?
I have not.
And myelofibrosis can be both primary as well as secondary.
Yes, sir.
So you need to divide that also.
Yes, sir. I have not separated it. Yes, sir.
Marrow aspirate would have been for the purpose of most of the
yes,
findings.
So
what is the additional advantage of doing a trephine biopsy in your study?
So it was just a morphological assessment that how biopsy as a diagnostic tool is important. So I have not correlated it with aspiration or PBS. It was just about biopsy. It was just a spectrum.
I have one question. You mentioned the most common indication for which you did this bone marrow biopsy was pancytopenia. So before going for biopsy, did you perform aspiration? So you didn't show that data of bone marrow aspiration. You should show the data where aspiration is inconclusive, then we go for biopsy. Because biopsy, it is a very much painful procedure, so, and more invasive. So all the cases you did aspiration before going for, so that data we want to see actually. Okay, thank you.
Now, I would like to invite our next speaker, Dr. Shreyasi Ghosh, to present the topic Histopathological Spectrum of Gallbladder Disease and Clinical Radiological Correlation in a Tertiary Care Center in West Bengal, a retrospective study.
Good morning, respected delegates, professors, and my dear colleagues. I, Dr. Shreyasi Ghosh, junior resident from ESIC Joka, will be presenting a paper on histopathological spectrum of gallbladder diseases and clinico-radiological correlation, a retrospective study in a tertiary care center in West Bengal. First, I'll be speaking briefly about background of my study. The gallbladder is affected by a range of conditions from benign inflammatory condition to aggressive malignancies. Histopathological examination remains gold standard for definitive diagnosis. However, combining it with clinical and radiological assessment, it improves accuracy and planning. The objective of the study was to study the histopathological spectrum of gallbladder lesions and correlate them with clinical and ultrasonological findings. Along with that, to compare the specificity, sensitivity, and accuracy of ultrasonography with respect to neoplastic etiologies of gallbladder. The study was conducted in Department of Pathology for a time duration of 6 months from November 24 to April 25. It's a retrospective study with 133 specimens. I have included all the gallbladder specimens received in the histopathology section and excluded patients with incomplete records and inadequately preserved specimens. Relevant clinical, radiological, and histopathological findings were collected from patients' record. Post that, sensitivity, specificity, positive predictive value, negative predictive value, and accuracy were calculated for gallbladder malignancies. Next, coming to the results, out of 133 cases, female preponderance was shown. Female percentage was 78.2%, mean age was 44.97. The most common clinical presentation was right upper quadrant pain, seen in 54% of the cases. Followed by the ultrasonographical findings. The most common ultrasonographical finding was gallbladder stone, followed by discrete mass, and gallbladder sludge, gallbladder polyp. Also, gallbladder thickness was found. The most common histopathological diagnosis was chronic calculous cholecystitis, seen in 62.4% of cases, and adenocarcinoma of gallbladder was seen in 6% of the case. These pictures are photomicrographs stained with H&E stain. First pictures shows a diagnosis of chronic cholecystitis. Second picture, cholesterosis. Third picture of follicular cholecystitis. And fourth picture of a giant cell in a foreign body. The entire picture shows photomicrographs stained with H&E stain of adenocarcinoma of gallbladder showing perineudal invasions. Comparing the radiological diagnosis with the histopathological diagnosis, gallbladder stone was seen in 94 out of 133 cases. Out of that, 93 cases were of chronic calculous cholecystitis. Biliary sludge was seen in 8 out of 133 cases, most common being xanthogranulomatous cholecystitis. Discrete mass in 19 out of 133, most common being chronic calculous cholecystitis with cholesterosis. Gallbladder wall thickening in 10 out of 133 cases. Most common diagnosis being chronic calculous cholecystitis with cholesterosis, and polypoid lesions in 2 out of 133 cases, most common being chronic cholecystitis with mucosal polyp. So the specificity, sensitivity, and accuracy of USG in detecting malignancies were calculated as 90.4%, 87.5%, and 90.23% respectively. Concluding the study, Among 133 patients, 78.2% were female, showing increased incidence of gallbladder pathology in female gender. Most common histopathological diagnosis was chronic calculous cholecystitis in 62.41% of cases. Sensitivity, specificity, and accuracy of USG in detecting malignancy were 87.5%, 90.4%, 90.23% respectively. Hence, USG is useful preoperatively, however, it may miss malignancies. Histopathology can reveal significant unexpected findings, including neoplastic changes, highlighting the need for histological confirmation. Thank you.
Okay, quite a wide variety of findings you have given. Any metaplasias that you have found in any of this?
Yes, sir. Intestinal metaplasia I have found in 2 of the cases out of 133.
Only 2?
Yes, sir.
I think you have not looked for metaplasias so thoroughly. Otherwise, out of
yes, sir, it might happen.
You should have got much more.
Yes.
Anyway, what do you attribute to find the USG findings of discrete masses which were later found to be just chronic calculous cholecystitis and xanthogranulomatosis cholecystitis? What could be the reason for there being finding of a discrete mass? Usually, so this is a false positive
yes, sir.
Finding. And have you you mentioned the diagnostic accuracy of USG?
90.23%.
Yeah, but what about the negative predictive value and positive predictive value?
Yes, sir. I have also mentioned it here. The positive predictive value is 36.84 and negative predictive value is 99.12%.
So negative predictive value is pretty high.
Yes, sir. Yes, sir.
You have not matched your findings with your conclusions actually. That is what I was wanting to.
So my one is for 6 months.
That's a coincidence.
So that's a coincidence.
That's just a coincidence.
For that matter, why was this study, needed at all? Do you think without histopathology, you would do? That would help any patient. Histopathology is a gold standard.
Yes,
without
sir.
histopathology, you cannot go ahead with anything.
Yeah.
So only doing an USG. Do you think any patient you do an USG, operate that patient, and the gallbladder is just kept like that without doing histopathology would serve
No,
the
sir,
purpose?
No.
Right. So histopathology, you are writing histopathology can reveal significant unexpected findings. Obviously, that's why you have to send histopathology for each and every specimen. So I don't understand why at all you are doing this study.
So actually, I just wanted to focus. There is a huge discussion that do we all need to send all the cholecystectomy specimen for histopathological examination?
You have to.
Yes, sir. Yes, sir.
You have to. Otherwise, you will be caught in a legal case.
Yes, sir. That is the thing I wanted.
So that is actually I don't know. Why you thought of that is the reason I am asking you. Why did you think of doing this case? If you do not send even one specimen for histopathological study, and the patient comes back to you asking for a histopathology report, and if you say you have not sent that specimen, you are caught.
Yes,
Okay?
yes, sir.
It is not so great, particularly in malignancy. It is not about detecting gallstone, detecting malignancy.
Yes, sir.
You have some problem in the picture that you have shown also. The polyp you have shown, if that was operated, then that was completely, that is a small polyp.
Sir, there was no picture.
Polyp is not more than 1 centimeter, we should not operate. But your polyp is very small.
Also, these Ayushman Bharat schemes,
Yes, sir.
patients do not get money unless they produce that histopathology report.
Okay, sir.
So that also you should know.
Okay, sir.
Thank you. Next, I would like to invite Dr. Sushmita Kumari to present the topic microbiological profile and antimicrobial susceptibility pattern of bacterial isolates from post-caesarean section surgical site infections.
Good morning, respected judges, seniors, teachers, and all the delegates. I am Dr. Sushmita Kumari, postgraduate trainee in the Department of Microbiology from Jawaharlal Nehru Medical College, Bhagalpur. Today I am going to present my study on the microbiological profile and antibiotic susceptibility pattern of bacterial isolates from post-caesarean section surgical site infections. Surgical site infection after caesarean section contributes significantly to maternal morbidity, prolonged hospital stays, and increased healthcare costs, especially in resource-limited settings like ours. Identifying causative pathogens and their antimicrobial susceptibility pattern is vital for effective empirical treatment and infection control. Globally, the total prevalence rate of surgical site infection after caesarean section is 2 to 15%, but in India, the range is broader, between the 3.1% to 24.2%. Timely pathogen identification and resistance profiling are critical for antimicrobial therapy and control of the infection. The main objective of my study is to determine the microbiological profile and antimicrobial susceptibility pattern of bacterial isolate from surgical site infection following caesarean section in our hospital, Jawaharlal Nehru Medical College, Bhagalpur, Bihar. This study is a prospective observational study conducted in the Department of Microbiology from November 2024 to April 2025. We collected pus swab from the patient of caesarean section who developed surgical site infections. We collect two pus swab, one for the gram staining and other one for the culture. Culture is done on the blood agar and McConkey agar, and after that we incubate the plate for 24 to 48 hours at 37 degrees Celsius. Identification of the organism is done by gram stain and biochemical test. Antibiotic susceptibility test is done by Kirby-Bauer disc diffusion method according to CLSI guideline. Two pus swab were collected using sterile cotton swab and then immediately brought to the laboratory for processing. The first swab was used for gram stain examination and the second swab was used for culture and further biochemical identification. Antimicrobial susceptibility of the bacterial isolate was performed by Kirby-Bauer disc diffusion method. This slide shows the gram stain and the culture plate images of various bacteria isolated in my study. Now coming to the result, out of 147 cases, 97 cases shows the positive culture on the culture media, in which 3 were the polymicrobial infection. The most commonly isolated bacteria are Staphylococcus aureus, followed by E. coli, Klebsiella pneumoniae, Pseudomonas aeruginosa, and 3 were the polymicrobial growth, in which Staph aureus with E. coli is seen. These are the tables of antimicrobial susceptibility of all the 97 isolates, which conclude that the gram-positive organisms are more susceptible to linezolide and vancomycin, and gram-negative are more susceptible to carbapenems and amikacin. Multi-drug resistance is detected in 41.6% cases of gram-negative bacteria. In conclusion, Staphylococcus aureus and gram-negative bacteria predominates in surgical site infection, and high prevalence of multi-drug resistance is seen in gram-negative bacteria. This underscores the urgent need for local antibiogram surveillance and infection control practices and implementation of the antibiotic stewardship program. Thank you for your attention.
You haven't mentioned the proportion of multi-drug resistance in gram-positive bacteria. You didn't find any cases of multi-drug resistance in gram-positive?
No, sir. Because this study is only a 6-month study. We collected 147 samples, in which I think 33 were the Staphylococcus aureus, in which we did
So
not find
all
any
were
multi-drug resistance. Yeah.
sensitive. That's good.
Did you look for atypical mycobacteria?
No, sir. We didn't find any sample of atypical mycobacteria. Actually, in routine, we only done.
I think you have to actively search for that. You have to actively search for that. You have to consider in mind that this can be one of the common one of the causes, because particularly laparoscopic surgery, post-laparoscopic surgery, wound infection, this is a very common problem, atypical mycobacteria.
So, in case of multi-drug resistant bacteria in gram-negative, so what was the profile of those cases? How many? What was the prolongation or more disability or morbidity? Have you found any data? How many extra days they could have stand, and what was the antibiotic that should have been done?
No, sir, we don't follow that.
But it's quite big number, 47 multi-drug resistant. So
24 cases.
24 cases. That is also quite big number.
Yes, sir.
So what was fate of this? How many days extra they have to stay? You have to find it, because ultimately it is a human face. Got it. So you have to kindly follow those. Just 24 cases. What are the fate of those multi-drug resistant cases? Okay.
Okay, sir. Thank you, sir.
Now, I would like to invite our next speaker, Dr. Alka Kumari, to present the topic, Role of OCT and OCTA in Diagnostic Evaluation of Retinal Disorders.
A very good morning to respected professors, faculty, seniors. My topic is role of OCT, optical coherence tomography, and OCTA, optical coherence tomography angiography, in diagnostic evaluation of retinal disorders. The retina is viewed through the dilated pupils directly, as ocular media is transparent. It is a non-invasive diagnostic imaging technique which is non-contact, enables in vivo cross-sectional view, including topography and tomography. OCTA has emerged as a non-invasive technique for imaging microvasculature of retina and choroid. This is a picture of a patient undergoing OCT in our IOPD at this institute, and this screen is what, on this side we are seeing that there are various options of OCT. We choose that, and it is then attached to a system and report is generated. This is normal OCT finding. We can see the surface and the layers as well. From inner nerve fiber layer to outer plexiform layer, and choroid, everything is visible, and this is normal retina and choroid vessels. So the aim and objective was to discuss the clinical application of OCT and OCTA in diagnosing and deciding management protocols. Coming to methodology, 10 patients coming to IOPD were the study participants. A meticulous history was taken, and all these patients were having diminution of vision and clear ocular media. The ocular media was not hazy. 2 patients from each of these 5 categories were taken, and these diagnoses were initially made at slit lamp examination with 90D lens. So, mainly the clinical presentation in all of these categories is diminution of vision, and then on the fundus we can see that in diabetic patient there were flame-shaped and dot blot hemorrhages, and on OCT we could see the cystoid macular edema. And on the color graph we can see that there was thickness of foveal and parafoveal region, and in OCTA microaneurysms were seen, which is highlighted with the yellow color. In hypertensive retinopathy, there was diffuse retinal thickening more than 615 micron and honeycomb appearance. And on OCTA, there was decreased retinal flow, increased foveal or vascular zone. Then in ARMD, we are able to differentiate between the dry and wet variety due to the OCT. OCTA is characteristically used to diagnose choroid neovascularization in wet ARMD, and in dry ARMD we can see the brucines on the OCT. Coming to papillary edema and macular hole, we can see that in papillary edema on the OCT there was retinal nerve fiber layer opacification and elevation of the disc margin. And in macular hole, any layman can also see that there is complete loss of retinal tissue. So retinal topography, the surface study, and the retinal tomography, that is the layer study, is possible with this highly evolved and costly OCT machine, which is a very great blessing to healthcare sector, especially in ophthalmology. And OCTA is a non-invasive study for the retinal and choroidal vasculature, and it bypasses the complications of dye and injection. Thank you.
Started only 10 cases.
Sir, many cases were there, and out of which, sir, with the guidance of my faculties, we decided to focus on these 10 cases because of time constraints also in the presentation.
I don't understand your logic. If you have done 100 cases, you will show the statistics only, no? Nothing more than that.
Sir, I have completed
so
5.
how it is going to help in the treatment of the patients?
Sir, on the fundus,
You followed up these 10 cases and gave treatment?
yes, sir. And the treatment is different. For initially, all these patients are coming with diminution of vision. Vision is less than 6/36 in one eye or the other eye. Then after the anterior segment examination and then posterior segment examination, most of the time they look similar. But with this OCT and OCTA, we are able to see the pathology in exactly in which retinal layer.
I'm not
Yes,
asking
sir.
about that. What I'm asking is, you have diagnosed these cases and what kind of treatment? Did you treat them here or you referred them somewhere?
Sir, we plan them for anti-VGF. If there is macular edema, bevacizumab is given, and if macular hole is there, then we transfer them to higher center for the tamponade. So if OCT machine was not here, then we are not able to decide the different treatment management, because we are not able to get the proper diagnosis without this machine.
Have you ruled out other causes of diminution of vision like glaucoma? And,
yes, sir.
Those have been ruled out in
yes,
all
sir.
these cases. Because you might have
Sir,
dual pathology also.
So glaucoma cases also we can diagnose with this OCT, but that is a sea of very vast sea of topic and another set of topics. So we decided to focus on the retinal disorders. In that also, sir, we can OCT through the OCT machine easily we can see that the nerve fiber layer thickness is reduced, RNFL. So that is also a very big blessing for us through this OCT machine.
So why didn't you include any glaucoma cases in your study?
Sir, we tried to focus on the retinal disorders mainly. That would have been another sea of mega topic.
Thank you.
Thank you, sir. Thank you so much, Team INVESTICON.
Thank you. The next speaker is Dr. Nilanjana Chanda to present the topic antibiogram mapping of the critical care units with respect to multi-drug resistant gram-negative bacilli isolates from routine blood culture in a tertiary healthcare institution.
Good evening, respected judges, all the panelists present here and the other dignitaries. I am Dr. Nilanjana Chanda from Calcutta National Medical College, second year PGD. Today I present antibiogram mapping of critical care unit with respect to multi-drug resistant gram-negative bacilli isolated from routine blood culture in a tertiary healthcare institution. Now start from introduction. Bloodstream infection and sepsis, a significant cause of mortality and morbidity. Sepsis following bloodstream infection mostly evident in immunocompromised CCU patient. Nowadays, a rising threat of MDR organism are noticed in CCU patient due to extensive use of broad-spectrum antibiotic and invasive procedure. This is a significant challenge for further treatment and spread of antimicrobial resistance. Now come to the aims and objective. To detect multi-drug resistant gram-negative bacilli causing bloodstream infection in critical care units along with their susceptibility, if any, to other antibiotics. Now come to the material and methods. Study design. A cross-sectional observational study, study period October 2024 to April 2025. Inclusion criteria, all the non-repetitive blood culture sample from CCU. Exclusion criteria, repetitive blood culture sample, sample positive for gram-positive cocci and fungus. Sample size and technique, 200 non-repetitive blood culture samples from suspected patient of bloodstream infection were collected from CCU and processed in automated blood culture system BD-Bactec FX40. Identification and antibiotic sensitivity pattern of all isolate done by Vitec2 Biomeru automated ID and AST system. Now come to the result analysis. Among 200 blood culture sample, 73, 36.5% were gram-negative bacilli. Out of those isolate, 47, 23.5 showed growth of multi-drug resistant gram-negative organism. Here in the pie chart, distribution of MDR resistant gram-negative bacilli isolated from blood culture samples from CCU. Here we can see the Acinetobacter is highest present and the lowest present is E. coli. Acinetobacter percentage is 10.5% and E. coli percentage is 2% and other non-significant bacteria 0.5% and Acinetobacter followed by Burkholderia cepacia is the second highest. Now come to the antibiotic resistant pattern of MDR GNV isolated from culture sample, blood culture sample. Here we can see the non-fermenter bacteria Acinetobacter baumannii and Burkholderia cepacia and the lactose fermenter gram-negative bacilli Klebsiella pneumoniae shows the highest resistance in aminoglycoside, cephalosporin group and carbapenem group. Now come to the antibiotic sensitive pattern of gram-negative isolate. In spite of high resistance, these MDR bugs sensitive to levofloxacin, colistin, ertapenem, cefoperazone sulbactam and minocycline. Now come to the discussion. Our surveillance study revealed non-fermented GNV, Acinetobacter baumannii, is the commonest MDR bug, mainly in hospital-associated infection pathogen, followed by Burkholderia cepacia and Klebsiella pneumoniae. Acinetobacter baumannii were 100% resistant to aminoglycoside. Both the non-fermented GNV, 88 to 100% resistant to cephalosporin, 66 to 80% resistant to carbapenems, and lactose-fermented GNV, Klebsiella pneumoniae, showed 100% resistant to beta-lactam inhibitors and 80% resistant to carbapenem. All those findings corroborated with other surveillance studies by Sanjeevan Bhatt et al. 2022 and Mulchandani et al. 2017. Now, take-home message. On the further analysis, a ray of hope was revealed in that the MDR pathogen found here were still sensitive to levofloxacin, cefoperazone sulbactam, and minocycline. So, clinician can use those drugs as empirical treatment of sepsis. Now, come to the conclusion. MDR pathogen precipitate an alarming threat of spread of antimicrobial resistance in the community. ICU, being the hub of multi-drug resistant bugs, needs strict surveillance. Measures to implement robust infection prevention and control to mitigate the spread of antimicrobial resistance. The surveillance data will help the IPC team to formulate local antibiotic which guide the clinician to apply empirical antibiotic for sepsis management with subsequent escalation and de-escalation thereafter. This is a tool for further escalation antimicrobial stewardship program efforts. Those are my references. Thank you.
Presentation on the same, almost on the same topic. Can you tell me why this kind of resistance, MDR, that is very prevalent nowadays, why it is happening? What is your view about that? So who uses antibiotic and who diagnoses it? Who should write the antibiotic rather?
Actually, microbiologists suggest the clinician to prescribe this antibiotic.
Did they ask your suggestion anytime?
Yes, sir.
Did they ask your suggestion?
Yes, definitely. Microbiologists play
I've never heard in Calcutta that somebody, one clinician is calling over the telephone to microbiologist, what antibiotics should be given? The question is...
Yes, sir. Yes, sir. In our college, in Calcutta National Medical
College.
National Medical
For a
College.
long time. I worked there for a long time. Don't
But
say.
in these days,
The main
last
problem, you have just started your career, I tell you one thing. We don't have a team. The problem is we don't have a team. And we have a very, very... Okay, but is it means you have a combined round with clinician?
Yes, yes, sir. In
You are having
in every Saturday, we will go to the round in ICU.
What about the other days?
Sir? Oh, sir, no. I only take the CCU patient, not OPD patient.
So there are other departments also, and antibiotic resistance is a grave problem for the future generation. And our clinician will never understand that.
No, sir. That's why we will arrange every month infection control meeting.
Meetings is all right. Meetings is all right. Meetings are all right. Weekly round is all right, but it has to be done 24/7 in all the departments and all the wards, including OPD. Otherwise, it will never be. This problem will always linger.
And here we can also included the females and males, all the patient after 18 years. Not included the pediatric patient or NICU-PICU patient.
At least I know in one private hospital at Calcutta, INK, daily clinical meeting goes on for each patient.
Thank you, sir.
Now I would like to invite our next speaker, Dr. Amolpreet Kaur Saini, to present the topic, the correlation of USG findings with CT scan for evaluation of bowel pathology.
A very good morning to everyone. My name is Dr. Amolpreet Kaur Saini. I'm a third year PG in the Department of Radio Diagnosis in MGM Medical College. I'm here to present a case study of correlation of USG findings with CT scan for evaluation of bowel pathologies. I did this study under the guidance of our HOD and Dr. Professor Rizaul Karim sir. Diverse pathologies can cause varied morphological changes in the bowel, leading to similar clinical presentations due to bowel dysfunction or obstruction. CT is a versatile tool for precise assessment of the gastrointestinal tract, providing detailed information on gut wall, surrounding structures, mucosa, and it has improved spatial resolution, negative oral contrast, and phasic imaging. In intestinal diseases, ultrasonography often reveals wall thickening, mucosal abnormalities, peristalsis absence, and extraintestinal complications like mesenteric thickening, lymph node enlargement, and lesion vascularity. CT is now considered and commonly used to screen patients with intestinal symptoms due to its growing reputation as a reliable problem-solving tool for GIT disorders, low diagnostic error rates, and ability to provide comprehensive information on abdominal neoplasms, and it is widely available. Aim and objective of my study were to establish the role of ultrasonography in early detection of mucosal irregularity in bowel pathology, and to establish the role of CT in detection of mucosal irregularity in bowel pathology, and to evaluate the role of CT and USG in the diagnosis of various bowel pathologies, especially for the early diagnosis. This was a prospective investigation which was scheduled to span over 1 year period, running from March 2024 to February 25 in the Department of Radio Diagnosis. 50 cases were with clinical suspicion of bowel pathologies were referred to USG, and for further characterization, they were evaluated with multi-detector CT. Patients with abdominal symptoms, palpable abdominal masses, and bowel lesions detected on USG represent distinct groups seeking medical attention, each requiring targeted evaluation and management. Patients with a history of trauma and those unwilling to provide consent for scanning were excluded from the study. Stats were done using SPSS 10.5 version software, and the results are expressed in numbers and percentages. The results, benign bowel pathologies are prevalent in ages of less than 30 years, which accumulated up to be 33%, while malignant lesions were more common in the patients over 40 years of age, around 64.2%, and there was no significant sex predilection. Abdominal pain was the primary complaint in benign group, whereas weight loss and abdominal lump were the chief complaints in the malignant group. Intestinal tuberculosis emerged as the most common benign pathology, while adenocarcinoma was identified as the most common malignant condition. And upon comparing the final specific diagnosis, CT demonstrated an agreement in 94%, while ultrasound showed concordance in 90%. CT exhibited a higher sensitivity, specificity, and diagnostic accuracy as compared to USG in the diagnosis of both benign and malignant lesions. These were some of the conditions that were evaluated under benign pathologies, and in USG, we could see abdominal cocks, colitis, Crohn's disease, appendicular pathologies, intersusception volvulus, acute epiploic appendicitis, jejunitis or ileitis, and abdominal cocoon. And a total number of 36 cases had benign pathologies, out of which 34 matched, having a discrepancy in 2 of the abdominal cocks cases, which came out to be malignant adenocarcinoma on further investigations. Whereas in malignant bowel pathologies, the conditions that were identified were adenocarcinomas, lymphomas, GIST, which a total of 14 patients were evaluated, in which there was a mismatch in the adenocarcinomas, in which 10 which were diagnosed under USG under malignant, and 7 came out to match, in which 3 were tubercular and 2 were Crohn's. These were the similar pathologies were investigated using CTs. Further, the same patients were investigated using CT, and in which there was a mismatch of abdominal cocks in 1 patient in the benign, and there was a mismatch of 2 patients in the cases of malignant in the scenes of adenocarcinoma, where 2 of them turned out to be tubercular. These are some of my statistics evaluating and describing the various pathologies, and on USG we could see that there was a sensitivity of 94%, and specificity of 78%, a positive predictive value of 91%, and a negative predictive value of 84%, with a diagnostic accuracy of 90% for benign pathologies. Whereas the CT showed 97% specificity, 85% specificity, 94% PPV, and 92% negative predictive value, and a diagnostic accuracy of 94% in benign pathologies. Whereas for malignant pathologies, USG had a diagnostic accuracy of 90%, whereas CT had a diagnostic accuracy of 94%. These are some of my graphs depicting various stats that we discussed in the previous slide. A similar study by Patil Vai et al. Found that CT scan was most effective for diagnosing neoplastic abdominal lesions such as adeno-CA, lymphoma, and various surgical emergencies like intersusception or volvulus. Infective diseases can be diagnosed on USG or CT scan with more than 70% sensitivity. This is similar to a comparative study by Arun Kumar et al., which evaluated 75 patients clinically, that ultrasound should be initially used to screen all these cases, but in cases it is non-specific, CT should be done, as it has an advantage in not only detecting but also providing surgical planning based on different anatomical locations. A similar study by Kumar S. et al. Found that USG and CT both demonstrated high diagnostic accuracy for benign and malignant pathologies, with USG showing sensitivity ranging from 78% to 94% and specificity 78 to 94%, and CT exhibiting sensitivities from 85 to 97% and specificities from 85 to 97%. In conclusion, USG is the primary imaging choice for GIT symptoms, offering less invasive methods, patient comfort, and good diagnostic accuracy. And in cases of inconclusive USG results, CT becomes very valuable, and especially for identifying benign causes and offering more specific diagnosis that may impact management decisions. CT surpasses USG in evaluating benign and malignant lesions, excelling in staging colon tumors, detecting metastasis, assessing local infiltration. Its superior diagnostic accuracy has established CT as the preferred imaging modality for both small and large bowel pathologies. These are my references. Thank you.
Your IBD cases, you have just got, I think, Crohn's 4 cases.
Yes, sir.
There could be COX obviously is the most common condition in India, and there is always a difficulty in diagnosing or differentiating COX and malignancy, which you have highlighted. Which is the mismatch you said?
So COX and the adeno-CAs were the most common mismatch. On USG, in benign pathologies, there was 2 adeno-CAs which we identified as TB, misidentified as TB, because the presentation is more or less same, because we have irregular bowel wall thickening, mesenteric wall thickening, edema of the adjacent bowel loops, and extensive lymphadenopathy. So they are very hard to differentiate. And FNAC or CT, these further help us, and if endoscopic biopsy could be done.
And colitis, you mean ulcerative colitis or any?
So any cause of colitis we have considered.
Any cause of colitis.
So gastroenteritis also comes under that. So
you can't differentiate ulcerative colitis from
we can, but in initial early detection, they might look similar. In as the disease progressive, we might see those specific lead pipe colon, as well as a loss of hostrations, circumferential thickening. Those are late presentations. Here we are trying to detect them in early stages, so they might get confused with other pathologies.
But
so mainly on CT. When we did CT, these were what we did and followed up with. So not all cases.
I'm asking, confirmatory diagnosis has to be pathologically done.
Yes, sir.
So how many of these cases were actually biopsied and?
So the cases of colitis and all were followed up, and if it disappeared, then it had to be a benign pathology. For COX, here
may not be essentially.
Sorry.
No, that is a very sweeping assumption.
You could have vaccine waning.
Yes, sir. Vaccine waning course can occur. Yes.
It's not always
So not all cases were followed up with pathology, because here in our clinical scenario, many cases get referred up to higher centers, especially if we give out reports for adeno-CAs. Anything with CAs or GIST or lymphomas, if we give out, they do get referred. So not all cases end up in the pathology
This
department.
study only compares the findings of ultrasonography and CT scan.
Yes, sir. Yes, sir.
And your clinical history, and then you have arrived at diagnosis.
Yes, sir.
Suppose adenocarcinoma or lymphoma, these diagnoses must have some pathological backing. Otherwise, it's very difficult to say that this is a case of actually adenocarcinoma. I consider it adenocarcinoma. It may not be adenocarcinoma after. So pathological.
So
adenocarcinoma is not a radiological diagnosis.
Yes, sir.
Isn't it? This is a pathological diagnosis.
I have a question. Have you just examined the cases referred to your department for this investigation, or you actively searched any cases in the?
So the
or
incidental detections in USG.
Okay. Have you sent any suggestion to the medicine and surgery department that if you find this type of symptoms, you send to us, or you just collected the data that was referred to you?
So the data that was referred to us, because the most cases from surgery and medicine that end up in radiology have a diffuse abdominal pain complaint. So we evaluated whoever came, and whichever patient we could follow up or was admitted under the various departments was further evaluated with CT.
So you did not separately collected any history from the patient?
No, sir.
Sensitivity of 70% in benign cases,
Yes.
but was that your finding, or was that some other studies finding?
So the sensitivity that I could find under my study was these values are from my study, where the sensitivity of 94% and 97% in benign and 78% in malignant and 85%.
I think these are quite high for ultrasound to get above 90% sensitivity. I think more in the 70 to 80% range would be bit more acceptable. Considering.
So the cases here that present are very extensive, because a lot of patients get referred from many other centers. So we get very typical findings many a times. So,
but you are saying you were looking at early cases of ulcerative colitis and not well-developed cases.
So
you
that's why I didn't mention ulcerative colitis.
You're contradicting yourself.
So that's why I didn't mention ulcerative colitis. It could be any cause of colitis.
Okay, thank you.
Thank you.
Now I would like to invite our next speaker, Dr. Aman Goyal, to present the topic Evaluation of Intra-Articular Platelet-Rich Plasma Injection in Periarthritis Shoulder in Diabetic Patients, an observational study.
Good morning, respected chairpersons, judges, and my dear colleagues. Today, I, Aman Goyal, second-year orthopedic resident, is going to present on the topic evaluation of intra-articular platelet-rich plasma injection in periarthritis shoulder in diabetic patients. So, frozen shoulder is a debilitating condition causing pain, stiffness, and restricted movements of the glenohumeral joint. While several treatment options exist, the optimal approach is still debated. PRP has emerged as a promising therapy due to its various benefits discussed in subsequent slides. There are several other treatment options for this condition, like conservative management by wait and watch or NSAIDs, corticosteroid injections, PRP injections, hydrodissection using distilled water, and manipulation under GA. However, many of these treatments pose limitations, especially in diabetic patients. The main objective of our study was to evaluate the efficacy of intra-articular PRP injections, as steroid injections can cause blood sugar spikes and risk infections in these patients. So PRP is blood-derived plasma rich in platelets. Being autologous, it carries minimal risks of adverse reactions. The major advantages include as it contains growth factors like platelet-derived growth factor, transforming growth factor beta, insulin-like growth factor VEGF that promote fibroblast proliferation, collagen remodeling. Thereby, it helps in biological repair and regeneration. It also restore capsular elasticity and reduce fibrosis, thereby improving range of motion and function. So we included 31 known cases of type 2 diabetes mellitus patients diagnosed with frozen shoulder having age of greater than 40 and duration of pain greater than equal to 2 months. Patients having any history of trauma or any other systemic disorder affecting the joint were excluded. Functional outcomes were assessed using visual analog score and constant scores at 0, 2 and 4 weeks. Study protocol. Once the diagnosis was established, the patient was included in the study after being explained the whole procedure and taking the written consent. Then baseline measurements were measured using VAS and CSS scores prior to the intervention. After that, PRP injection was given following manipulation under anesthesia. Again, post-procedure, VAS and CSS scores were taken and were compared to the baseline values. This is the case 1 showing pre and post-procedure range of motion improvements. The patient experienced significant functional improvement after PRP injection, illustrating the potential of the modality in the clinical practice. Case 2 and 3 have similar findings. Both patients exhibited substantial improvements in shoulder movements. Results. The mean age of participants was approximately 60 years with a higher female prevalence. Right shoulder was more affected commonly. Preliminary data indicates that PRP injections post manipulation resulted in improvement range of motion, reduced pain and better functional outcomes. The VAS score and in this slide you can see the VAS score decreasing and the CSS score increasing in subsequent follow-ups, which indicates that the patient had improved functional outcome in by a study. On this slide, we have the detailed data. The VAS score showed a significant reduction in pain over 4 weeks, with most patients reporting considerable pain relief by the 2nd week itself. The constant shoulder score also showed progressive improvement over the 4-week period. This objective data supports the clinical improvements. Conclusion. So here I conclude my study with the take-home message that intra-articular PRP injection following manipulation appears to be a promising treatment for frozen shoulder in diabetic patients. Functional improvements were consistent with existing literature. No complications were reported. However, larger prospective studies are needed to further validate these findings and optimize the PRP administration protocol. Thank you.
Thank you. Why did you choose only diabetic patients? Why not non-diabetic patients? They also have a frozen shoulder.
Yes, sir, but in diabetic patients, we generally can't give steroid injections or any other modalities which are already thoroughly researched. But PRP is a new modality, and first of all, frozen shoulder is very common in diabetic patients. Secondly, we can't use NSAIDs or can't give them steroids for longer period of duration. So, plus there were many less studies showing the role of PRP in frozen shoulders, so that's why I chose this topic.
What's the contraindication of using NSAIDs in diabetic patients?
Sir, over the prolonged periods, it can lead to diabetic nephropathy. It can aggravate the diabetic nephropathy.
You use prolonged for maybe 2 or 4 weeks duration. I think the usual protocols are.
But sir, the cycle of the frozen shoulder, if any intervention is not done, lasts for over 9 months. So that's why the PRP injections were.
PRP injections, how many doses have you given over this time?
Sir, one dose, and in some patient, a second dose at 2-week follow-up were given.
We used only PRP or PRP with growth factor and other addition of calcium
No, sir,
chloride,
we used
etc.
only PRPs by double spin method. We made it by double
No
spin.
addition of growth factor like biotin or calcium chloride.
No, sir.
Okay. Very good.
Thank you.
Thank you. Our next presenter is Dr. Ravneet Kaur to present on the topic third trimester Doppler assessment of the fetal MCA peak systolic LV velocity in GDM, a cross-disciplinary lens into cerebral hemodynamics and sudden IUD risk.
Good morning, everybody. The topic of my paper presentation is third trimester Doppler assessment of fetal MCA peak systolic velocity in GDM, a cross-disciplinary lens into cerebral hemodynamics and sudden IUD risk. Gestational diabetes mellitus is defined as glucose intolerance with onset or first recognition during pregnancy. It affects 1 to 14% of pregnancies depending on the population and diagnostic criteria. While GDM often presents without overt symptoms, its subclinical impact on fetal physiology is significant. Chronic intrauterine hyperglycemia can cause fetal hypoxia, leading to compensatory erythropoiesis and polycythemia, which increases blood viscosity and may reduce fetal blood flow velocity. The fetal middle cerebral artery is particularly sensitive to such hemodynamic changes. Doppler assessment of MCA PSV offers a non-invasive marker of fetal adaptation to hypoxia, anemia, or acidosis. In hypoxic states, blood is redistributed to vital organs like the brain, a brain-sparing effect commonly seen in preeclampsia and growth restriction. However, data on MCA PSV changes in GDM remain limited and inconsistent. The study aims to fill that gap by evaluating MCA PSV in pregnancies with well-controlled versus suboptimally controlled GDM during the third trimester, 32 to 35 weeks. Our ultimate goal is to assess whether MCA Doppler changes can serve as an early warning tool for sudden intrauterine death, particularly in cases where maternal glycemic control is poor despite routine monitoring. The objective of my study was to compare MCA PSV in optimally versus suboptimally controlled GDM during routine third trimester screening and assess its predictive value in identifying fetuses at risk of sudden IUD and early neurodevelopmental delay. An observational pilot study with analytical elements was conducted among 20 singleton pregnancies at MGM Hospital, Kishanganj, Bihar. Participants were divided into Group A and Group B. Group A was suboptimally controlled GDM with fasting blood sugar values more than equal to 90 milligram per dl, 2-hour postprandial values more than equal to 120 milligram per dl, or HbA1c more than equal to 6.5. And group B was optimally controlled GDM with fasting blood sugars less than 90 milligram per dl, or 2 hours postprandial less than 120 milligram per dl, or HbA1c less than 6.5. Inclusion criteria: singleton pregnancy, euglycemic in 3rd trimester, GDM female with suboptimally controlled blood sugar. And exclusion criteria was multifetal gestation, PIH, RH alloimmunization, pregestational diabetes, maternal anemia, refusal to consent. Result: the study included 20 women, 10 in each group, whose median middle cerebral artery PSV was calculated for group A and group B. The median MCA PSV was lower in group A, which was the suboptimally controlled GDM, than in group B, optimally controlled GDM. However, this difference did not reach the statistical significance, as the p-value was equal to 0.17. The trend towards decreased PSV is clinically relevant and may reflect increased blood viscosity secondary to fetal polycythemia as a response to chronic intrauterine hypoxia. An interpretation of the scatter plot with the regression line, wherein MCA PSV was on the y-axis and HbA1c was on the x-axis. There is a weak negative correlation between HbA1c levels and MCA PSV. That is, as HbA1c increases, MCA PSV tends to decrease slightly. However, the p-value is 0.272, which is not statistically significant at the 95% confidence level. Conclusion: the MCA PSV was decreased in fetuses of women with suboptimally controlled GDM. This reduction is likely due to fetal hyperviscosity caused by polycythemia secondary to chronic hypoxia. MCA Doppler can serve as a valuable predictor of fetal compromise and sudden IOD, even when other fetal parameters remain within normal range. Regular 3rd trimester Doppler screening along with fetal echo to rule out hypertensive or non-hypertensive cardiomyopathy, especially in GDM cases with poor glycemic control, may enable timely intervention and improve perinatal outcomes. These are my references. Thank you.
Thank you. Your statistically, it's not significant, your findings. So,
No.
how can you conclude any robust conclusion cannot be made from your study?
So, since this is a pilot study, we had only 20. The sample size was only 20. The study group included 10, and the control group included 10. So, we can extrapolate the study like what we are planning, that during the delivery, we can collect the cord blood sample and we can calculate the packed cell volume. If it is more than 65%, the normal value has to be around 45%. So if it is more than 65%, we can actually rule in hyperviscosity on the basis of biochemistry findings and ultrasound.
Why have you kept anemia as outside the study? Anemia is one of the exclusion criteria.
Sir, because hyperviscosity is the only thing that has not been concluded as of yet in any study. We have studies on chronic anemia. We have studies on hypertensive disorders in GDM.
No, are you saying that anemia is confounding factor?
So anemia itself, like the physiological anemia in pregnancy itself has variable. Like it itself causes fetal anemia, and during the later gestations, there are some false negative values after 35 weeks of gestation. So we've tried to exclude that to reduce the false negative.
Anemia in pregnancy is much more common compared to GDM. So you might falsely miss out anything.
If the patient is anemic, what will happen to the PSV?
So the MCA PSV will increase.
In anemia?
Anemia, MCA PSV will increase.
Increase.
Yes, sir.
Okay. So now you are excluding that confounding factor.
Ji, sir.
Okay. So the study will be completely biased.
Sir,
It
we
should be
actually want.
anemia should be matched on both sides.
Sir, we wanted to focus upon the fetal factors. We wanted
But
to
that is
predict
not
the
possible
sudden.
because all these factors independently will also affect PSB, isn't it?
Yes, sir.
So one thing,
You need
please
a
go
very
to the method
large
section.
volume, large sample, then it probably
Please go to
will
method
come.
section. I'm back. Yes. Acha, from where you got this level of fasting blood sugar less than 90, 2 RBP less than 120? From where you got these values? Which standard? Is WHO standard or European standard? Which standard? ICMR. Fasting blood sugar less than 100 to 110 is the standard method of control, and less than 120, 140. So from where you got these standards?
So this was on the basis of the studies that we had already. There were 3 other papers which we had already.
No. Fasting blood sugar at 2 hour PP, etc. You cannot compare with previously published paper. You have to compare with WHO or ICM or something. Got it? So
Yes.
it is again it is another bias study, because you have made many % GDM based on this. Those who are telling optimally controlled, they are totally biased study. You have made a lower standard for GDM control.
Sir, mainly in my study, we use the HbA1c criteria more than any of the other criteria, because each of the criteria says or like it's either fasting or postprandial or HbA1c. So the the graph that I have plotted is based on the HbA1c versus the MCA-PSV. Ji, sir.
Anyhow.
Sir, I'll take that.
Whenever you see and give reference to WHO, ICMR, American Diabetic Association, anyone, you have to mention.
Yes, sir.
Which standard you have used.
Yes, sir. Thank you, sir.
Thank you. Now, I would like to invite on stage our judges of poster presentation for felicitation. I would like to invite Professor Dr. Nupur Nandi ma'am, Professor Obson Gynae, Professor Dr. Vishwakant sir, Professor and Head of Department of Forensic, Professor Dr. Anupam Khalko sir, Professor Anatomy, Dr. Nikhil Ira sir, Associate Professor Pharmacology, to come on stage for felicitation. Now, I would like to invite Professor Dr. Nirvana Haldev ma'am to felicitate our judges, Professor Dr. Nupur Nandi ma'am. Thank you, ma'am, for accepting our token of gratitude. Now, I would like to invite Professor Dr. Mala ma'am, Associate Professor, to come. To come and felicitate our judge, Professor Dr. Vishwakant sir, Professor and Head of Department of Forensic. Thank you, sir, for accepting our token of gratitude. Now, I would like to invite Dr. Avinash, sir, Assistant Professor, to come on stage and felicitate our judge, Professor Dr. Anupam Khalko, sir. Thank you, sir, for accepting our token of gratitude. Now, I would like to invite Dr. Shubhayan Das Gupta, sir, to come on stage and felicitate our judge, Dr. Nikki Leira, sir. Thank you, sir, for accepting our token of gratitude.
लेते हैं फिर बाद में देखेंगे। हाँ कुछ ज़रूरत हुआ तो ले लेना। या प्लीज़ माउस पैड ऑल्सो आई रिक्वायर ना माउस पैड
पॉइंटर दे देंगे हम।
नहीं ये नहीं हो रहा ना ऑन
पॉइंटर है
The first topic. The first topic for today's session is Doppler in Fetus by Dr. Aarti Singh Ma'am, Senior Consultant, Fetal Medicine, Fernandez Hospital, Hyderabad. I would like to request Ma'am to please come on stage. The next, I would request Professor Dr. Shekhar Chakrabarti Sir, Professor and HOD, Department of Obs and Gynae, and Professor Dr. Rizal Karim Sir, Professor and HOD, Radio Diagnosis, and Dr. Chandni Sehgal Ma'am, Associate Professor, Department of Obs and Gynae, for chairing the session. Thank you.
Whether it is connected or not, how can I know? Okay.
Hello. Hello. Children. Hello, good morning everyone. I'm very happy to welcome Dr. Aarti Singh. She's MBBS, MS, Obs Gynae, PMCH Patna. She's a Senior Consultant, Fetal Medicine, Fernandez Foundation, Hyderabad, an Executive Member of SFM, Telangana. She's done her senior residency in Medical Genetics and MRH from SGPG IMS, Lucknow, postdoctoral fellowship in high-risk pregnancy and perinatology, NBE, New Delhi. Her areas of interest is fetal neurosonogram, fetal echocardiography, and invasive fetal testing and therapy. She's a fellowship in obstetrics ultrasound from Mediscan, Chennai. Welcome you, ma'am.
Thank you for your kind introduction. First of all, I would like to thank INVESTICON 2025 for giving me this opportunity to be here, to be the part of this academic event. And my topic of discussion is fetal Doppler. And my storyline will cover the brief introduction about the Doppler, followed by the role of Doppler in obstetrics, and then we will discuss some interesting cases for the better understanding of the subject. So what is Doppler? If I will ask you, being a medical professionals, we know that a lot of physics are there to understand the Doppler. From clinical point of view, for we obstetrician and fetal medicine person, we know that it is the ultrasound-based non-invasive method of assessment of feto-maternal hemodynamics. That is the most practical definition of the Doppler. So what is the indication? If we see in the modern obstetrics, it plays the crucial role starting from the first trimester and throughout the gestation. And it has the role in all kind of the prevention. Primary prevention in the form of first trimester, fetal screening for the fetal aneuploidy, and the maternal preeclampsia screening. You all know the well-established role in these two aspects. And secondary prevention for the diagnosis of fetal growth restriction and fetal anemia. And not only that, once this disease established, there is role of Doppler for the management and for the prevention of the complications, especially the fetal growth restriction and fetal anemia. So today I am covering mainly the role of Doppler in the fetal growth restriction and fetal anemia, although just now I spoke about the role of Doppler in diabetes mellitus, but till now there is no established role in this area according to the Fetal Medicine Foundation UK. So maybe in the future it will come out, but at present, mainly it has role in the fetal growth restriction and the fetal anemia. So now coming to the principle of the Doppler ultrasound, and for that we should have the basic understanding about the 2D Doppler. So 2D ultrasound. So how 2D ultrasound is different from the Doppler ultrasound? For that you should understand first 2D ultrasound. What is 2D ultrasound? Here the probe produces the ultrasound wave, and this is the red one, which strikes over the stationary reflectors. I will repeat again. It is the stationary reflector. Maybe it is a adult liver, kidney, or fetal brain, and abdomen, whatever. And it reflects back, and you can see these green waves are the reflecting back, and it is received by the probe. And here, there is no change in the frequency. So whatever frequency emitted and whatever received, both has the same frequency. So both wave have the same frequency. That's why in the 2D ultrasound, echo from the stationary tissue are same from pulse to pulse. But the Doppler principle is little bit different. And for that, we should take one day-to-day example. You might have noticed one fact that when you are waiting for your friend at a railway station, to receive your friend or family member at a railway station, so you might have noticed this fact. Just you see what is that effect. Well, sound is not there. What should I do? Sound is not coming. No, laptop sound is on. Because it's ultrasound, so we are very much interested to know about the sound. So I request you all to listen this sound and just make your feeling what kind of the perception you have. So what did you notice? Here, when train approaches towards you, the sound goes up and up. And when the train leaves the station, the sound goes down and down. So why it is happening like this? Because there is relative movement between the sound producing source and the observer. And same thing holds good for the Doppler ultrasound. So what happens, you can see this is the blood vessel, and inside the RBC is moving. And when the ultrasound probe produce a ultrasound wave with a certain frequency, and when it strike over the moving RBC, and when it return back, it has a different frequency. Okay, so this change in the frequency between the received frequency and transmitted frequency is nothing but it is the Doppler shift. And if you see the formula to calculate the Doppler shift, there is a very complicated formula. So different things you have to multiply, like sound wave frequency, probe frequency, blood vessel flow velocity, and also the speed of the sound in the soft tissue. So here I would like, because you all are clinician, you should remember this angle, theta angle. This angle is nothing between, it is the angle between the ultrasound beam and the moving RBC. And this angle should be always maintained 0 degree to get the better Doppler shift. So what happens, this Doppler shift, which is actually the received frequency minus transmitted frequency, it is received on the ultrasound screen as the ultrasound waveform. So whatever Doppler waveform you are getting on the screen is nothing but it is the Doppler shift. So Doppler shift actually is the signature of a blood vessel. So just like for we human being, our nature and signature never changes. The same way, every vessel has its own Doppler wave pattern, and you can see it is a signature of that blood vessel. So you can see the Doppler wave pattern, how they are different from vessel to vessel. Uterine artery Doppler, how it looks. Umbilical artery Doppler is different from the uterine. Similarly, middle cerebral artery and ductus majoris, so they have their own signature and wave pattern. Now, what this wave pattern saying to us? Actually, this just like ECG in adult, the ultrasound wave pattern, each component actually represents the different phases of the cardiac cycle. So here it is the arterial waveform, which is usually it is biphasic in nature. It has a systolic component here, and it is the diastolic component. And let us see, the systolic component actually depicts the pumping capacity of a heart, and the diastolic component represents the peripheral resistance, that is the resistance at the level of the placenta. Now, coming to the next Doppler is a venous Doppler, and usually you should remember, unlike arterial Doppler, which is biphasic in nature, most of the venous Doppler are triphasic in nature. So here you can see it resembles the badly written alphabet M. And its first spike depicts actually the peak systolic velocity, and the second spike actually is the first phase of the diastole. So whatever I'm talking in terms of the ventricle systole, ventricular diastole, and this phase is the A wave, which represents the late diastolic flow or arterial contraction. So what happens with this component, systolic and diastolic component, with its different combination, we can calculate the different indices, Doppler indices, like HD ratio, systolic by diastolic ratio, RI, resistance index, which is systolic minus diastolic divided by systolic, PI, pulsatility index, systolic minus diastolic divided by the mean. Mean is the systolic, it is the mean of the systole and diastole. So here, important thing that these Dopplers, these ratios are gestational age dependent. So it varies from gestational age to gestational age. And good thing is that these ratios, because being a ratio, it has the denominator and numerator, it is not affected by the insonation angle. As I told you, the insonation angle is very important. Always maintain as much as possible to the 0 degree, or sometimes it is allowed up to the 20 and 30 degree. But here, these ratios, they are independent of the insonation angle error effect. So now the question comes, which Doppler indices to be followed? I'm just talking about the obstetric Doppler. Don't confuse with the radiology, because they are our gynecological scans, their RI and all are important. But from the obstetric point of view, you have to remember that pulsatility index, PI, is the most commonly indices in the current practice for both arterial and venous Doppler while you are managing the fetal growth restriction. And when you are dealing with the fetal anemia, it is the mid-cerebral artery peak systolic velocity which is important. From today onward, from obstetric point of view or from fetal medicine point of view, you should forget all other indices, RI, SD ratio, although it was very much in use in the previous era. But now we should remember only two indices, RI for the FGR management and peak systolic velocity of the middle cerebral artery for the fetal anemia. Now, how to interpret the pulsatility index? So let us see, as I told you, these indices are gestational age dependent. So you can see this is the y-axis is the PI value, and this is the x-axis, this is the gestational age in weeks. So what happens, that you can see here 3 lines. The two red lines, it is the lowest limit of the normal, that is corresponding to the 5th centile, and it is the highest limit of the normal, that is the 95th centile. And in between it is the green line, means showing the mean value. So let us plot one PI value. So here it is a 34 weeks 1 day fetus with the PI value of 0.83. I am not interested in SD ratio and RI. because I am dealing with the obstetric scan. So I will plot the PI value. So let us plot 0.83 against the 34 weeks. So where it is falling? Where it is falling? So normal value or abnormal? Obstetric department, if anyone is here. It's a normal value because it is falling between these two red lines. Okay. So now coming to the normal physiological change of the Doppler waveform over the gestational age. So here important thing is that uterine artery, Doppler, umbilical artery and the ductus venosus, they all have the similar kind of pattern. So in the earlier part of the gestation there is less diastolic flow, and you can see in all vessels similar kind of the pattern. In fact, in the uterine artery you can see the early diastolic notch, but at the gestational age advances there is increase in the diastolic flow because of the lower flow resistance and because of the PI will decrease. But if you see the middle cerebral artery, the pattern is totally different. Here, normally it is the high resistant flow blood vessel and diastolic flow is very low and PI is the high. That is the normal finding. This is the basic thing you should remember while you are dealing with the fetal Doppler. Now uterine artery Doppler in the late second and third trimester, you should, if you get the finding like this with the good diastolic flow and no diastolic notch, it is a normal and reassuring sign. But if you get the picture like this, where there is less diastolic flow with the diastolic notch, your antenna should raise because you are dealing with some baby who are at risk because of the fetal growth restriction. So rule of thumb, high uterine artery PI with without persistence of diastolic notch beyond 24 weeks actually depicts the incomplete trophoblastic invasion of the maternal spiral artery. Okay. Now this is one clip of the uterine artery Doppler. Now moving to the next vessel, umbilical artery Doppler. So you can see what is the normal pattern with the high diastolic flow. But when there is fetal compromise in the form of fetal growth restriction, initially what happens, initial stage there is less diastolic flow. You can see the PI value will increase. Later on, once it progresses further, there is and diastolic flow. You can see in the diastolic flows there is no flow at all, and in the advanced stage it is the reverse diastolic flow. So suppose you are getting the picture like this where the less diastolic flow and more PI, it means 30% of the placenta has gone. It is not working. And if it is the absent diastolic flow or it is the reverse diastolic flow, it means 50% or 70% of placenta respectively is non-functional now. So Doppler wave pattern itself saying you what kind of problem baby is facing. So please look the Doppler pattern and make the diagnosis. Now umbilical artery Doppler, how to take, it is another lecture, so we'll skip. Now I am just making you to understand about what is a normal waveform, what is the abnormal waveform. At least if reports comes to you being an obstetrician, you can make out that difference between the normal and abnormal. So here it is the middle cerebral artery. You can see what is the normal pattern. As I told you, the normal pattern is the less diastolic flow. But if you're getting the pattern like this, where the systolic component is very much increased, that means you are dealing with the fetal anemia. And if you are getting the pattern where the diastolic flow is very high, you can see now when it resembles like the umbilical artery waveform. So whenever you are performing the middle cerebral artery Doppler, you are getting the umbilical artery wave pattern kind of waveform, again you should be alert. Am I dealing with the fetal hypoxia or fetal growth restriction? So that will give the clue. So now middle cerebral artery Doppler, I'm skipping all the small videos how to do because this is a separate discussion. Now coming to the next, after discussing all the arterial Doppler, let us move to the venous Doppler. So here also the normal waveform with the good diastolic flow. As the fetal compromise advances, there is less diastolic flow followed by the absent diastolic flow, and ultimately it is the reversal of the A wave. And here important thing is I want to share with you that venous Doppler actually depicts the terminal stage of compromise when the fetal cardiac failure, where the fetus is in the cardiac failure, or in this stage when there is reversal of the A wave. Actually, it is well correlated with the fetal acidosis, and this is the reason because being venous Doppler or ductus venosus Doppler depicts the terminal stage of the compromise, it is the surveillance tool of choice for the early onset growth restriction. So now, cerebro-placental ratio, CP ratio, very popularly used and famous ratio. So that is, what is the ratio? It is the ratio of the medial cerebral artery PI divided by the umbilical artery PI. And it reflects the preferential blood supply at the expense of the other viscera in response to the fetal hypoxia. So whenever there is fetal lesion compromise and fetal growth restriction, fetal tries to supply more and more blood flow to the brain, and this leads to increase in the PI value of the MCA Doppler. So what happens here, it is also gestational age dependent. You can see this graph, it is the gestational age dependent CP ratio, and less than 5th centile anywhere is the abnormal finding. And you should remember the normal, when you are getting the CP ratio more than 1, although graph is there, you have to see the gestational dependent chart, but you should remember in your clinical practice, when you are, the CP ratio is more than or equal to 1, it is a normal finding, and less than 1 is defining the fetal brain sparing effect, and it is the surveillance tool of choice in the late onset FGR. Why it is the surveillance tool of choice in late onset FGR, we'll discuss now. So now, fetal surveillance tool for the FGR, it depends upon whether you are dealing with the early onset FGR, which appear before 32 weeks, or late onset FGR, which appear after 32 weeks. In the early onset FGR, it is the severe degree of placental disease leading to the increase in the umbilical artery resistance, and afterload will increase. Because placenta is diseased, heart has to push hard to supply the blood, forward blood flow, and there is heart decompensation. And you know that precordial veins, which is very near to the heart, that is the ductus venosus Doppler. Just like jugular pulse in the adult, ductus venosus is playing the same role in the fetal life, and that's why when there is severe degree of compromise and cardiac decompensation, ductus venosus Doppler will be abnormal, and that is the reason it is surveillance tool of choice in the early onset FGR. Similarly, if we see the late onset FGR, it is a mild degree of placental disease. That's why it appears late. So what happened here? The umbilical artery Doppler is almost normal till the end, and that will give you the false impression that everything is fine. But because at this point of time, brain is mature, baby's brain is mature, and it is sensitive to the even the mild degree of hypoxia, and that's why even the little bit change in the blood flow and little mild hypoxia can also affect the brain perfusion, and that's why in the late onset FGR, CP ratio plays it is the surveillance tool of choice. I hope I'm clear. You should remember, in the early onset FGR, heart is the predominant one, and that's why precordial vein, which is the ductus venosus, is the surveillance tool of choice. And the latter part, late onset FGR, by the time brain is mature and sensitive to the mild hypoxia, that's why CP ratio is the surveillance tool of choice, along with the modified biophysical profile. So with this little bit of the discussion, let us see some case-based scenario. So first case, primary mother, low risk mother, irregular period. Previously, her 2-3 scans were done outside, and she came to you at 32 weeks as a referral saying that the growth lagged by the 3 to 4 weeks. So you can see here the graph. This is the red lines, and between there is green lines for the BPD, head circumference. For every parameters there is the one chart. So what you can see, all parameters are below the fifth centile. You can see the red line, all are below fifth centile. So what kind of pattern it is? What is your next plan of action? Any obstetric department PG? Would you like to do Doppler at this point of time? Anyone? Please raise your hand. Don't hesitate, just it's a discussion, whatever we have learned till now. Are you missing something here? I'm saying it's a referral case. So you are missing something here. It's a very important thing because patient comes to you very late at 32 weeks. So you are missing the dating of the pregnancy. That plays a crucial role when you are plotting the growth chart. So same thing, we have always you ask, whenever patient comes to you at a late gestation, always ask for the previous reports, and especially the first trimester report to make out the dating problem. You have to sort out first, then only you have to growth of the baby. So we did the same, and you know there was a correction of the date, and now the corrected growth curve plotted. And you can see everything is within the limit. So you can see how the dating of pregnancy made such difference. So don't forget your basics. Although you are discussing the Doppler, you should always stick to your basic knowledge, and you know with that baby turn out as the fetal AGA baby, average for gestational age. So the learning lesson is that first confirm the gestational age before plotting the growth curve and decide about the growth pattern. And always it is rule of thumb, CRL between 8 to 13 weeks, 6 days is the most reliable method for the dating of the pregnancy or gestational age determination. Now moving to the next case, 30-year-old mother, booked almost low-risk mother. She is in the ideal scenario. She is with you from the beginning of the pregnancy. You have done the early pregnancy scan, anti-scan, anomaly scan, everything done well and good. There is no scope to do the dating in this case, and patient presents to you at 34 weeks for the growth scan. So here you can see, here at 34 weeks, BPD is normal, head circumference normal, femur length normal, and what you can see here, it is the abdominal circumference which is less than the fifth centile, and that is affecting the effective fetal weight of the baby, and the fetal weight is only 8th centile. So what is your diagnosis? This is the small baby. So what is the definition of small baby according to the different guidelines? It is almost decided by the most of the guidelines. Effective fetal weight or abdominal the given threshold, and that was decided less than 10th centile. So whenever you are getting less than 10th centile, always you should label that baby as the small for gestational age. So now small for gestational age babies are the two types. Maybe it is because of the wrong dating, or it is really small. So how to make the diagnosis for that? You have to do the dating, and we have done, and we have excluded that part. Now we are left with the really small babies. Sorry. So now really small babies are also of the different types, like constitutionally small, or you can say it is the healthy small babies. Constitutionally small because the family built babies are smaller, and that constitutes 75%, most of the contributed by the healthy small babies, and 20% by the starving baby or pathologically small babies because of the placental abnormality, and very small minority of means small number of cases because of the abnormally small non-placental cause like chromosomal anomalies. But the good thing is this kind of this group of babies with chromosomally abnormal, they usually present with the multiple anomalies and early onset FGR. So that is not the problem. You can make out the difference. So main problem to differentiate between this constitutionally healthy small baby and the pathologically small babies. So what you will do next, and why it is important to identify fetal growth restriction from the small babies. So always you have to differentiate between SGA babies, which are normally grown small babies, and other is the pathologically small or FGR babies, because it is found that the FGR babies has very poor outcome. And the SGA baby has almost normal outcome just like the normal babies, and that's why it is crucial to differentiate between these two groups. So who will help to differentiate FGR versus SGA? It is again the Doppler. So which Doppler you would use? Which Doppler you would like to use for differentiating between the SGA and FGR baby? Would you like go with the only umbilical artery Doppler? How many you wants to go with only umbilical artery Doppler? So previously umbilical artery Doppler was considered as the surrogate for the fetal compromise, and it is solely used to differentiate between the SGA and FGR. But in the studies it was found that so babies which was labeled as the SGA based upon the umbilical artery Doppler, majority of the cases turn out with the abnormal outcome. That's why umbilical artery Doppler no longer used as a standalone criteria to differentiate between FGR and SGA. So the new concept came, multi-vessel Doppler, which constitute umbilical artery Doppler, umbilical artery, middle cerebral artery, and ductus venosus. And there is rationale why we are shifted to the multi-vessel Doppler against the umbilical Doppler alone. So because each component is saying something. Uterine artery is saying that placental development is not good. If it is abnormal, means degree of trophoblastic invasion is not proper. Umbilical artery, it actually depicts the placental function. And middle cerebral artery gives the idea about the centralization of flow towards the brain in response to the fetal hypoxia. And ductus venosus, I already discussed, it always depicts the forward cardiac flow, and when it is abnormal, it depicts the terminal stage of the fetal compromise. So now to summarize, effective fetal weight less than 10th centile. What you will do? First, you will apply all arterial Doppler, uterine, umbilical, and middle cerebral artery, and you have to ask two questions, whether the effective fetal weight is less than 3rd centile or Doppler abnormalities are there in uterine and the umbilical artery. Suppose both are fine, that means you are dealing with SGA baby, and if abnormalities are there in this too, that means you are dealing with the fetal growth restriction. To summarize, to simplify, SGA babies are the baby with the effective fetal weight between 3rd to 10th centile with the normal Doppler. Although they are small, but their Doppler finding is normal, and they are between 3rd to 10th centile. And if the babies are between 3rd to 10th centile with the abnormal Doppler, or if the effective fetal weight is less than 3rd centile without any Doppler change, is also the FGR. So for SGA, the management plan is totally different. You have to repeat the ultrasound every 2 weeks, and you can go up to the 40 weeks to deliver, depending upon the other obstetric complication. But when there is fetal growth restriction, we have to impose the next line of the Doppler, that is the venous Doppler. After arterial, we have to do the venous Doppler, and we have to do the staging of the fetal growth restriction. And the fetal stage-based management protocol was given by Barcelona team, Gratacos et al. In 2014. It's very user-friendly protocol. So let us see what is the stage-based management protocol for FGR proposed by the Barcelona team. It is the stage 1, mild placental insufficiency, and here it is a mild change in the Doppler will be there. The stage 2 is a severe placental insufficiency, and here is the absent and diastolic flow in the umbilical artery Doppler, and MCA is also less than 5th centile. The third stage is the depicting the low suspicion of the fetal acidosis, and here the ductus venosus Doppler PI will be more than 95th centile, and umbilical artery Doppler, that is reversal of flow, reversal of the flow. And the fourth stage, which is the terminal stage, actually depicts the high suspicion of the fetal acidosis, and almost baby is about to die at this stage. And here you can see the ductus venosus, there is reversal of flow in the A wave. So actually ductus venosus is equivalent to the computerized CTG. And in the truffle trial already it has been proved that even you are not equipped with the facility of the computerized CTG, you can use ductus venosus as the surrogate for the computerized CTG. So ductus venosus is a very, very strong tool. Now you have assigned the staging of the FGR baby. Now you have to give the management plan. So in the stage 1, it is the monitoring at weekly interval and delivery at 37 weeks. With either you can induce more, induction can be done, or cesarean section depending upon the obstetric indication. Stage 2, you have to do more intense monitoring, bi-weekly monitoring, with the delivery between 32 to 34 weeks. And here mode of delivery always should be the cesarean section irrespective of the finding. Now stage 3, more intensive monitoring. Every alternate day, every day or every alternate day you have to monitor the baby, and you have to deliver the baby by 30 weeks by cesarean section. And here I'm thinking you are making the sense that always such babies are delivered under protection of steroid and the magnesium sulfate for neuroprotection. So I'm not saying that. Stage 4, that is the high suspicion of the fetal acidosis. Here the intensive monitoring, even twice a day, is not sufficient. More than that also is required, and you should deliver the baby as early as possible. It depends upon your NICU facility of that hospital. For a Fernandez hospital, we have 650 gram baby at the 26 weeks is the viability criteria. So depending upon your hospital, what kind of NICU facility, you should deliver the baby at stage 4 earliest. Now, it looks very complicated how to remember all the staging, what to give the management plan, because it's very, very complicated. This Doppler, this kind of finding, so it's very difficult, but always we have some way. And Barcelona group has actually given us the very good software. And for that, you have to go to the Google and you have to type fetal medicine Barcelona, and the web page will open. So you can see this is the fetal medicine Barcelona, and then you go to the fetal growth section. And it will ask you what is the gestational age, what is the last period of gestational menstrual period, and it will ask you what is the effective fetal weight on the basis of your scan. So these 3 things you will fill, you will give you the idea about the plan. So let us plot one case on the Barcelona software. It is the 37 weeks and the fetal weight is 2204 gram. And let us plot 37 weeks 2204, and it will ask you Doppler. It will actually guide you further also, when to do Doppler, when not to do Doppler. So here, the Doppler finding were plotted umbilical artery, uterine, and MCA Doppler plotted, and the DV Doppler. And you can see miracle. It is giving the idea what state it is now, and also it is recommending the plan to the clinician. But here, you should remember it is a software, it's a AI generated. It will give you plan, but you have to think for your patient. If suppose mother has some other problem, you have to manage accordingly, but it will give you the plan based upon the fetal growth value and the fetal Doppler. Now coming to the next important scenario, 30-year-old is a very low risk mother, all scans were done. It's a chronic hypertensive patient, and growth scan done at 28 weeks and 32 weeks. So at 28 weeks it is 82 centile, so well and good. But the same patient comes to you at 32 weeks, it is 21st centile. So what do you think? Is it a normal finding? Anyone, obstetric department? 82 centile, now it is 21 centile. It's a normal finding? It's more than 10 centile. Are you okay with that? 82, 21st. Are you okay? 10 centile more than? No, good. Because why? There is drastic fall in the fetal weight. So, crossing centile also matters. Although baby is lying within the normal range, more than 10 centile, but still I am worried because this baby has the reducing growth trajectory, and Delphi consensus also included this crossing centile is one of the criteria to define the fetal growth restriction. To what happened in this case, because, sorry, 5 more minutes. So crossing centile, we have performed the Doppler, and it was turned out of the FGR. So new concept, fetal growth restriction exists in 2 subsets. SGA less than 10 centile, even AGA baby can also be FGR baby. So SGA less than 3rd centile weight, irrespective of the Doppler, or when the effective fetal weight between 3rd to 10th centile with the abnormal Doppler is the FGR. Not only AGA baby with the crossing centile with the abnormal Doppler is also is the FGR. So 3 type of the FGR baby can exist. So just one good case for you. This mother, primary mother scans were done, all were good. And you can see scan is a S centile, Doppler normal, but mother has the high BP. And urine protein 2+, LDH 400, SGPT 150, platelet 90,000. So although Doppler finding is giving the reassurance, baby is good, almost good, but here the mother is not well. So what you will do? Will you rely on Doppler finding and go ahead? No. Always holistic approach. You should see the mother as well. So careful consideration, mother as well as the fetus, holistic view is always important. So can I skip this? Is a RH isoimmunization because time is not permitting. Okay. So this mother, she is RH negative mother, and first pregnancy she was not covered. Although fetal demise at 16 weeks, entity was not covered. And second pregnancy she developed hydrops at 26 weeks, and third pregnancy she presents to you at 12 weeks. So what is next? ICT test, we all know. ICT came as 1 is 32. In titer, it is the RH isoimmunized pregnancy. So how to monitor and why to monitor? Because fetal is at risk of fetal anemia because of the crossing of the maternal antibody. And at which titer you have to start monitoring, irrespective of the ICT finding and why it is, how to monitor. So would you like to do ICT again, or would you like to plot the Lilly's chart with amniocentesis and based upon the fetal bilirubin value? No, these all are obsolete now, and it is the era of the, what is the, that is fetal Doppler. MCA Doppler will guide you about the management plan. It is not ICT, not Lilly's curve. And MCA PSB is the gold standard, And when to start the monitoring, it is 18 to 20 weeks. Always, because by this time, reticular endothelial system develops and there is crossing of the antibody, as well as you should do your surveillance only once the viability, you are in the stage when you can provide certain kind of the fetal therapy. So before 20 weeks, you cannot do intrauterine blood transfusion. So always better to do the MCA Doppler from the 20 weeks. So what is the pathophysiology, you all know. So I'm skipping. And MCA PSB Doppler, why it has been chosen, because you know its orientation, God has made like that. The incidental angle itself will be 0 degree. That's why it is the golden standard test for the fetal anemia management. And with the experienced hand, it has sensitivity of 100% and negative predictive value is also 100%. It means if the experienced person has done the MCA PSV value and it is saying there is no anemia, means no anemia at all. So how to plot the MCA PSV? We are doing with the Marie chart. So here it is the median centile, that is 1 mom, 1.29 mom and 1.5 mom. And based upon these 3 moms, we are dividing the graph into the 4 zones. D zone, no anemia. You have to call the mother as 2 to 3 weeks interval. C and B is also non-anemic zone. And here you have to call the mother as 7 and 5 days interval respectively. A zone is the anemia zone. Always remember A means anemia, and you have to transfuse at that point of time. So you can plot 25 weeks and the MCA PSB is 40. You can plot it is falling into the zone B, it is non-anemic zone. Now, one of our baby we have plotted from the beginning, and you can see how the plotting has been done over the time. So initially it was in the D zone, then it is in the B zone, C zone, then B zone, and gradually at 25 weeks it landed into the A zone. And at that point of time, we have done the blood transfusion, intrauterine blood transfusion, and later on we have followed every 2-3 weeks. Again, at 35 weeks, again baby was anemic, and transfusion was done 2 times for this pregnancy. And if you have Mary's curve, well and good, and you are not with the Mary's curve, better you take help from the Google. You have to type perinatology.com, and you have to write the gestational age as well as the MCA PSV value. It will give you the mom value, and it will guide you what should be your management plan. Now, the one important, just 1-2 slide more, it's a very important tips and tricks I would like to share with you. Suppose you are in front of the patient will ask you, Dr. Saab, is my baby is anemic? So that time you will not open your Google, you will not ask for the Mary's curve, because patient should also impression doctor is knowing something. So you should also idea about the baby, how to see the MCA PSV value and how to make the diagnosis from that value. So here this is the reference chart. You can see gestational age. It is the median value of the MCA PSV, and it is a 1.5 mon, which depicts the anemia. So what we can see at 20 weeks, 1.5 mon means anemia, which is depicting anemia is the MCA PSB is the 38 centimeter per second. At 30 weeks, it is the 60. So what you can make from this? It means if MCA PSV value is 2 times of the gestational age in weeks, actually corresponds to the 1.5 mom for that gestational age, that is depicting the fetal anemia. So when you are doing a scan at 30 weeks and MCA PSB of 60, that means you are dealing with the fetal anemia. Then and there you can answer to the patient, your baby is anemic, you need the intrauterine blood transfusion. So you all know, so we can say that MCA-PSB for the diagnosis of fetal anemia has been one of the few discoveries in fetal medicine that changes the standard of care in the management of the affected pregnancy. And this has led to the more than 60% reduction in the number of the invasive tests. So previously, we used to do the amniocentesis, and from that, bilirubin we are detecting, and we are plotting over the Lilly's chart. So that all invasive tests now gone, and it is replaced by the non-invasive tool, that is the MCA-PSB. So it is actually the game changer for the management of the fetal anemia, and the credit, all credit goes to this Austrian physicist. So you know who is he? Is Christian Doppler, who has given the principle of the Doppler principle. And the interesting thing is that he has not detected Doppler principle from the ultrasound, from the sound wave, but it is from the different things. That is the light wave. So he is the one who noticed that. So why in the sky the star is coming towards us and going away from us? That is twinkling effect because of the relative motion between the star which is producing the light and the observer. And from there, there is the beginning of the Doppler principle. And same thing hold good when you are doing the ultrasound, Doppler ultrasound. And he has given this principle almost 150 years back, and it took 100 years, more than 100 years to understand his principle and to apply in the medical field. So in his honor, always you should write Doppler from the capital D. So with this, I would like to end my session. For any question, I am open. Which ma'am? Algorithm. Okay. FGR algorithm you are asking, ma'am? Stage based or what? No, I got. Yeah, I understood. No, you can open Barcelona stage-based management. Everything is very clear. Where should I? This one you are asking, I think. Hannah? Yeah, sorry. So that's why I told you no need to remember. Just you go to the Google Barcelona. At present, it is free of cost. It's okay, ma'am?
I have got some query.
Yeah.
One is, in early pregnancy,
Hello.
ductus venosus Doppler for aneuploidy screening, should it be used or should it be abandoned?
We are using.
At what weeks of registration?
11 to 13 weeks, 6 days, anti-scan. This is one of
no,
the...
anti-scan I am not talking about, I am talking about ductus venosus.
Ductus venosus we are using for the aneuploidy screening.
You are using?
Yeah.
But
so
I think Isuk has said that NIPT should be the preferred method than doing Doppler because of the fetal effect.
Sir, definitely. For the high resource setting, NIPT is replaced the first semester screening. But a country like India, we are using the contingent screening. In my hospital, we are using contingent. First, we are labeling the baby based upon the initial markers like the nasal bone and maternal parameters, fetal heart rate, and ductus venosus Doppler and tricuspid Doppler. Based upon that, we are labeling the babies into the 3 groups. Whether baby is falling in the high group or the low risk group. And intermediate group, we are offering the NIPT.
And high
to
group
reduce the cost.
High group you are directly going for...
we are doing the invasive test. And low risk, we are doing routine test.
So this one part. Second part is, suppose you are suspecting that isoimmunization may occur very early, where your intervention may be very difficult. like 18 weeks, baby is developing ICU immunization.
Usually it will not develop, sir.
No, आपको reticuloendothelial system gets mature by 16-18 weeks, so it can happen. But thing is that, is there any process of delaying intrauterine transfusion by giving IVIG?
Yeah,
Are you practicing
IVIG,
it?
they have tried, but it is not well established till now. And also plasmapheresis also people had tried. So what some people are doing, they are doing intraperitoneal transfusion also. Suppose it's a very resistance case, every time it is happening. So we can do like that also.
Okay. Now third question is, suppose after once transfusion has been done to a fetus, so next time this peak systolic value 1.5 multiple median should be accepted, or their value should be different?
Actually, it is not that much correlated as like the first transfusion we are doing.
So
but
what do you take the cutoff?
Other way. No other way. So what we are doing, we are transfusing up to the PSV of the 45. And we are expecting every day it is reducing by 1. So 15 days. By the time it will reach that 30. So like that, all things we are taking consideration. Also we are looking at the baby also. Baby has high drops and all. Accordingly,
advanced.
But yeah, that much not correlated, but there is no other way. It is one of the component, the deciding point.
Thank you. This is a very nice presentation. You have to accept it, and I think our PGTs will get a lot of benefit from your lecture. Thank you very much.
Thank you, sir, for the opportunity you have given me.
Thank you, ma'am, for such an interesting and engaging presentation. I'd like to request Dr. Chandni ma'am, Dr. Shekhar Chakrabarti sir, and Dr. Rizal Karim sir to felicitate our speaker. I would like to request Dr. Aarti ma'am to come on stage for felicitation. Now, I would like to request our speaker, Dr. Aarti ma'am, to felicitate our chairperson. Thank you, sir. Thank you, ma'am. The next topic for today's session is antimicrobial resistance, which will be presented by Professor Dr. Mukesh Kumar Sir, Head of Department of Microbiology, NSBMCH Bhita. I would like to request Professor Dr. Nupur Nandi Ma'am, Professor, Department of Obs and Gynae, MJ Medical College, Kishanganj, and Dr. Shakuntala Singh Ma'am, Department of Obs and Gynae, for chairing the session.
So we are privileged to call upon Professor Dr. Mukesh Kumar to present his presentation on the antimicrobial resistance. And he is currently the professor and head of the department of Netaji Subhash Medical College and Hospital, Bihtar, Patna. He has 12 years teaching experience and one ICMR research project on his occupancy, and he has more than 35 publications, of which book chapter contribution also 4, and he has many certification and fellowships in the form of ACME and fellowship in infectious disease. NABL internal auditor he is, and he is also the resource faculty for ACME at the regional center, the IGIMS Patna.
Thank you,
sir.
ma'am,
The
for
dais is yours.
introductions. And very good afternoon. I'd like to thank Dev sir and Ashok sir, the entire investigation team, to having me here. And I'll not take much time. I'll just sensitize on it. Okay. As you know, that empirical therapy is not optimal, and as per the CDC, we have seen that up to 50% of the antibiotic which are used currently, it is unnecessary and inappropriate. It totally depends where I am using that antibiotic empirical therapy. In the sepsis patient, it is 47%. It is that it is not used optimally. So sepsis with the AMR, what? No, take it, fine. With increasing this bacterial resistance and limited new antibiotics, we know that there is no new antibiotic is coming up. Even the mild infections may become untreatable and lead to the sepsis and the death. Sepsis with this resistant pathogen found to have higher risk for the hospital mortality, and the appropriate use of diagnostic and therapeutic is also critical to prevent such development of this resistance. And if you see this index across the countries, we are having higher rate. For this, we need a diagnostic stewardship. Question comes, what is this diagnostic stewardship? So the main goal of this diagnostic stewardship is to select the right test for the right patient, generating accurate, clinically relevant, actionable result at the right time to optimally influence the critical care and to conserve the health case resources. In this goal, there is a early goal-directed therapy and sepsis bundle care. That is most important. Question comes, what is EGDT? Actually, the principle for EGDT is identify high-risk patient, appropriate culture, source controls, early administrations, initial resuscitation, followed by early hemodynamic approach. The use of EGDT, it has been seen that it can reduce 28-day mortality in the sepsis patient, and sometimes if you take all the parameter, we call it as a bundle or sepsis resistant bundle or sepsis bundle. Why to promote this bundle, care bundles? To produce the better outcome than the individual actions. And if you see those bundles, the first hour bundle, yes, the lactate label, obtain blood culture prior to administer antibiotics. These are the diagnostic things, very important as early. Administer broader spectrum, begin rapid administrations of crystalloids and apply vasopressors. And to optimize this blood culture sensitivity, the pre-analytical parameters are very important, and those includes the number of blood sets, time of blood culture between the two sets, volume, time of incubations, delay incubations. So these are all parameters which are compared. It has shown that very good output as per the CLSI. And as the volume increases, the recovery of pathogen is more and early therapy can be given. Why we prefer automated culture systems? Because it is a complete microbial detection system. It has antibiotic neutralization capacity. Even if the antibiotic has given, it can neutralize if you take this next sample before the giving antibiotics. Multi-layer plastic bottle, that's safety of the sample, healthcare professional, unique identifications, colorimetric technology, faster results, and the best is quality control. That is the most important thing. Each is loaded with the separate quality control. And how to interpret? So once, if you see the antibiotic, the most important word, that is minimum inhibition concentration. What is it? Actually, it is the lowest concentration of antibiotic that inhibits the visual growth of a microbial isolates. In vitro is totally depends upon the method we use. There are various methods for MIC, will not go in that detail. Types of antibiotic we use, microbial agent we are using it, and this MIC have a clinical relevance until it is interpreted in the context of the drug, the microorganism, and the host property, that is PKPD, that is the most important. So the goal is that to predict this in vivo response, but when testing in the in vitro. So AST interpretation mainly depend upon the breakpoints. And these breakpoints is standardized, and it is given by the two important sets, that is CLSI and the UCAST. And this MIC is totally depend upon the PK parameter, including the volume, concentrations, area under curve, clinical outcome, elimination times, and these 3 points, that is the PK data, MIC distribution, clinical outcome. So with this comes why we should go and how to interpret this MIC. That is most important, because most of the result or the report you get, the MIC is written, but it has not been interpreted properly, and sometimes it goes seen that treatment failure. So MIC, it is the most accurate, and it is a specific, mandatory for certain microorganism. If I'll give you certain examples, we do the disc diffusion. And if in this, if you can see the pulse culture with a disc diffusion technique, we find that a Staph aureus has been isolated, and it is resistant to the oxacillin, cephalexin, vancomycin. It has been given sensitive. But once it has been done with the automation and MIC is calculated, then we have found that it is resistant to the oxacillin, cephalexin, and vancomycin. The MIC will be given, and that comes as a MRSA. So CLSI state that MIC test should be performed to determine to the susceptibility of all isolates of staphylococci to the vancomycin. The Dix test does not differentiate the vancomycin susceptible isolate of S. aureus from the vancomycin intermediate isolate, nor does the test differentiate among the vancomycin susceptible? So we can miss the VIC. There are certain drugs for which MIC has to be done, like fosfomycin in case of Enterobacteria except Escherichia coli and Staphylococcus aureus, TG cycline, colistin in all gram negative rods, but sometimes we have found in certain reports that they have disc diffusion, they have tested and given the report. All antibiotics in case of Neisseria and anaerobics, beta-lactams in penicillin susceptible Streptococcus pneumoniae, glycopeptides, lipoglycopeptides in Staph aureus, dalavancin, autravancin in Streptococcus group, Viritans, AVC. We have to test the MIC, we cannot test it on the disc diffusion. This MIC helps in the phenotypic based resistant mechanism detections. CLSI guideline has removed many method of phenotypic detection. Newer method has been introduced, but in MIC sometimes we miss that type of resistance, and this MIC, when it comes from the automated system, it gives the what type of resistance is there. For example, in uric culture disc diffusion test, we have given this ceftazidime intermediate, ceftriaxone, cefepime. These are intermediate, and others are resistant and sensitive has come. But once the correct, if the same thing has been tested in the automation and MIC, we have found that it is a ESBL producer and CTX type. So here phenotypic mechanism has been given by the system. So it is very easy that we can label as ESBL, and that has lot of limitation. It can say that these are the group of drugs which cannot be act on this, whether it is intermediate, because in mind it is there that okay, if it is intermediate, we can give the higher dose and a patient will respond, but it is not like that. The better management of the critically ill patient, yes, we have seen that 30% of the critically ill patients received inadequate therapy for the bloodstream infection, and as a result 62% of the group have mortality. For this, in critically ill patients, later you have received the sample, there is a one word that is fractional inhibitory concentration index can be calculated. And what is this? Where we can see the synergy between two drugs and antagonistic, how to use those things. So you can calculate it. For example, if we have a drug A antibiotic, drug B antibiotic, and then you calculate the ratio of that single and the combination, and then we'll find that if index is less than 5, then it is a synergistic effect, and we can give the treatment accordingly. So this is the very important role or MIC. Why to consider this MIC in the gram-negative organism? Yes, there is a lot of BI and BLI choices for various infections like bloodstream infections, that lactamase inhibitor combinations, and once, because the choices is ultimately the carbapenem group of the drugs. This MIC does it related with the dose or not? Yes, it is related to the dose, but both are different, but it has relation to the dose and dose, because it is the in vivo, the minimum concentration and dose we decided, the clinical dose we give, and we can calculate as per the guidelines. So how can we optimize this antibiotic exposure? It totally depends upon the therapeutic index, that is the break point what the CLSI has given, and the minimum MIC what we have got, and that we calculate is the therapeutic index. And it totally depends that the antibiotic diffusion in the site, मतलब किस site के लिए हम लोग use कर रहे हैं, right? Infected site. Another is the drug doses for concentration technique, for the concentration dependent and the time dependent. So like chloroquinolones, aminoglycolines, they should be given higher doses. And for the time-dependent antibiotics, beta-lactam and vancomycin, we have to give frequent dosing and the increased duration of the infusion. I'll give you one case scenario where a 72-year-old male admitted to the ICU for nursing home with shortness of breath and respiratory failure. And COPD has been, diabetes and obesity were there. Culture was sent for sputum, and we found that it was Pseudomonas aeruginosa, and these are the antibiotics. Lab report says sensitive to all the agent, and initial therapy with the cefepime started. But does we have checked the therapeutic index? So as per the UCAST or as per the CLS, with those antibiotics, with the MIC and CLSI, it says that the therapeutic index for the ciprofloxacin is 8. And it has a better diffusion in the lung. So here, we have given with the cephalexin, patient does not respond. Ultimately, we are shifted to the ciprofloxacin, and then based upon is the therapeutic index and its perfusion to the lungs, and then patient has improved later. One more comes, that is the BMQ. That BMQ is the breakpoint to the MIC question. Why this is important? As you know, therapeutic index we have discussed now. The therapeutic efficacy is the most important now here. I'll give one example that lab gives Escherichia coli is susceptible to the amikacin. MIC is 4 and cefepime MIC is 1. As a clinician, low MIC, I'll give the cefepime as a treatment. But here we need to think that actual amikacin is more effective compared to the cefepime because of the higher BMQ. So breakpoint in the CLSI it is given 16, and we have got the 4 as a MIC. So once you divide it, it comes as the BMQ. And similarly for cefepime, breakpoint is 2, and we have MIC has come 1. Then we divide by 1, it is 1. So 4 and 1. So that's why the efficacy, therapeutic efficacy of Amica is better than compared to the cefepime. That's why we should prefer BMQ is another. So how can we come to know this? It is only happen if the clinicians or the critical care, at least they start with, as in the morning I have seen that some of the institute has started it. So once it start communications with the treating physicians, with the microbiologists, when they're stuck with the MDR and all, because they think the MDR means no, it is not like that. We can give. There are still options are there. We can treat those patients also. So for that, we need therapeutic effects index and need to be calculated, and for that you need to take the help of the microbiologist. PKPD, yeah, this is the most important, because sometimes unless we MIC, it totally depends on the PKPD value of the antibiotics. Most of the pharmacology we have studied. So how it is related? See, there is a certain antibiotic which are dose dependent. Matlab concentration is more important. There are certain antibiotic that is time dependent. So you have to give higher dose, higher maximum doses. Some you have to give for a longer duration of time. It's totally dependent upon the whether the area under curve, the time, and the maximum concentration reach in that body side, the infective side, the cavity where. So based upon this, we have 3 state types are there, 1, 2, and 3. So type 1, that is the concentration dependent killing. Type 2 is a time dependent killing. And these are the certain antibiotics where you can see this who come under category of type 1, type 2, and type 3. And accordingly, the goal therapy depends that whether should I give the maximum concentration or should I increase the duration of exposure of my drugs, or accordingly we plan depending on this PKPD or MIC if you draw the curve. And this you will get help from the microbiologist if you're stuck somewhere in the treating your critically ill patient. So to optimize this on the basis of PKD, there are 2 things: time dependent, beta-lactam, and fluoroquinolones aminoglyceride, that is concentration dependent. So accordingly, increase the frequent doses, prolong infusion, or single dose, single shot with the high doses can be depending upon whether it concentration dependent or it is a time dependent. Can you calculate the dose with this MIC? Yes, we can. ऐसा नहीं है कि जो dose दे दिया गया है that dose I have to give. नहीं. Depending upon, because it varies, person to per is varies. हो सकता है उस dose में काम नहीं कर रहा. So with the help of MIC, we can consult with the microbiologist and we can decide the dose. हो सकता है recommended dose is given certain, but once we calculate with the MIC, PK value, find the dose is little bit more. So with the help of this formula, Cmax, volume of distribution, the systemic availability, you can calculate the dose, and might be there will be a improvement in the patient also. So these are the certain advantages of MIC. And this is last slide because pre-lunch we are stated there. So in short, I'll tell you there is certain myths and facts of the MIC that MIC is the highest dilution or lowest concentration showing no visible growth. It is not true value, impossible to determine the true value. The test challenge in the inoculum is determined by the use of 10 to the power 5 CFU per ml, does not depict the true bacterial inoculum at the site. The minimum in the MIC is not the strict minimum but observed minimum, as I discussed earlier. MIC is less than 60 means MIC could be from 9 to 15. MIC does not represent in vivo concentration. Lower the MIC, bear the antibiotic? No, as I told you, it is not like that. Lower the MIC is the phenotypic endpoint in the defined and standardization, but a highly relative systems. MIC measures in vitro is not what always happen in the vivo, you know that. And standard measures of the activity of the drug against the bug. So with this, I conclude that antibiotics are non-renewable resources, so utilize them wisely and utilize automation for the better outcome of your patients. Thank you.
Thank you, Dr. Kumar, for your wonderful, nice, and informative presentation. And it is very useful for the clinicians to determine the antibiotic treatment. So this is very useful.
Yes.
And it will help because this problem is day-to-day problem in the clinician's practice, and it's a very burning problem.
Yes, ma'am, it is there.
Thank you, sir.
Thank you,
As a clinician, actually, we just see the reports of sensitivity
Yes.
and all. So today, just after this session, I could have known the better. We should always communicate with the microbiologist while choosing antibiotic, and the integration of the microbiology department with clinicians are very much needed. So the importance of MIC and the breakpoints and all. If the audience have any question to sir with such a thoughtful way, they can ask.
Most of the time we have seen that in the ICU setup, the clinicians, ma'am, MDR is there now, they thought you don't have any choices. But with the help of MIC, we have given them certain therapeutic index and efficacy, and after treatment they have found improvement. It's nothing like that, all the MDR we can, XDR we can't give. It is not like that, ma'am. But still hope is there, like synergism, antagonism, we'll see with the two MICs, and then we can give, ma'am. It is helpful once communication starts.
Yes,
definitely will come out with the solution.
And
so that we have to begin that.
Dose dependent and time dependent
Yes,
approach also,
Yes,
for which antibiotic what should be the best, and tailoring according to patient situation. Really it is very thoughtful.
Yes, thank you, ma'am.
Thank you, sir.
Thank you, sir. Now, I would like to request Dr. Shakuntala Singh ma'am and Dr. Nubhu Nandi ma'am to please come forward and felicitate our speaker. I would like to request Professor Dr. Mukesh sir to kindly accept our token of gratitude. Thank you, sir. Now, I request Professor Dr. Mukesh sir to kindly felicitate our chairpersons. Thank you, sir. Thank you, ma'am. The next topic for today is non-invasive assessment of liver fibrosis, role of serum biomarkers by Dr. Indrajit Nath, sir, Additional Professor Biochemistry, AIIMS Guwahati. I would request Professor Dr. Tapan Mukherjee, sir, Professor and HOD, Department of Biochemistry, and Professor Dr. Sanjay Kumar, sir, Professor, Department of Pathology, MGM Medical College, for chairing the session. Thank you.
Dr. Indrajit Nath, sir, he is additional professor in Department of Biochemistry, AIIMS Guwahati. He is MBBS from Silchar Medical College and MD from Guwahati Medical College. His areas of interests are clinical chemistry, non-communicable disease, and immunology. He has many experiences. He was formerly Associate Professor, Department of Biochemistry, NEIGR IHMS Shillong, Meghalaya, Department of Biochemistry, and North Bengal Medical College, West Bengal. More than 30 years of teaching experience, teaching and research experiences in the field of laboratory medicine, has been guided and co-guide of postgraduate MD students since 2015. PI and co-PI in various intramural and extramural projects, has got several publications in international and national journals national journals. Sir, I request you to go ahead.
Thank you, sir. Thank you for the nice introduction. Good afternoon to you all. So today's topic, as you can see, it is non-invasive assessment of liver fibrosis, role of serum biomarker. So at the very outset, what I want to say is that when I was being asked to present a topic in this INVESTICON, so I thought, right, what can be the most relevant one? So thinking about the observation of Global Fatty Liver Day on 12th of June, this 12th of June 2025, I found this topic to be very much relevant in this context. So what I'll do is that I'll be covering the topic under this following heading. So discussing about the pathophysiology, a very must to know if we have to further go with the discussion. We will be dealing with the importance of assessment of liver fibrosis and then the need of non-invasive markers, categories of serum biomarkers, the direct, indirect, and the panel that we have in the market and that is very much utilized in the clinical practice. What is their clinical utility, advantages, limitations, emerging trends, future direction, and last I'll conclude. So if I have to say about the pathophysiology, so I can just finish it off in a single slide. So any sort of insult to the liver may it be in the form of a viral infection. As you know, hepatitis B virus is a chronic sort of infection if it stays. Alcohol insult, non-alcoholic fatty liver disease. So these are all the primary insult that the liver has. And in that case, the hepatic stellate cells and the Kupffer cells gets activated and they become fibrogenic. Hepatic stellate cells in particular convert to myofibroblast. And then they start secreting the extracellular matrix, which ultimately leads to fibrosis. So that's done. But let us dive a bit more into it, into the cellular and the molecular features. So what happens, right, when if we say about the cellular and molecular features, a very brief sort of, so in this diagram, what we can see is that So it's not working. Is this? It's not working. The cursor is not working. Okay. In the first diagram, what you can see is that there is a hepatic sinusoids, like the sinusoidal endothelial cells which are fenestrated. They line it nicely, form the basement membrane, and they separate it from the space of this. So, okay. So इसमें करना पड़ेगा यहाँ पे. हाँ. Okay, fine. Got it. Okay, so what we can see is that these are the fenestrated endothelial cells lining the sinusoidal sinusoids, hepatic sinusoids, and we see the nicely these Kupffer cells are lying there. These sinusoidal cells, they line and they become a partition between the space of this and the hepatic sinusoids. In the space of this, we have the hepatic stellate cells. So any sort of insult and injury to the liver, the Kupffer cells, they start secreting fibrogenic mediators. So what these fibrogenic mediators do, they change the phenotype of the hepatic stellate cells. So as you must be wondering why I'm discussing this, because this is where the basis of those markers lies. So what these hepatic stellate cells were basically in the normal stage is that they used to have 60 to 70% of the retinoid droplets. They were secreting the type 4 collagen because the basement membrane is basically the non-fibrillar collagen, which we know is type 4. But as the insult occurs and there is a signal from the Kupffer cells, the signal in the form of transforming growth factor beta and PDGF. So what happens is that they change, there occurs a phenotypic change. The retinoid droplets, they are all vanished. This hepatic stellate cell starts secreting type 1 and type 3 collagen. So they are basically the fibrillar collagen. So this is where the basis of the extracellular matrix and the fibrosis starts developing. So this is what we discussed. Further changes, what happens with this hepatic stellate cells, what they can do, they become fibrogenic, well and good. They start secreting matrix metalloproteinases. Also tissue inhibitor of matrix metalloproteinases. So matrix metalloproteinases, they try to degrade the synthesized ECM. And what TIM does is that they prevent it. So there occurs an imbalance between the STIMP and the matrix metalloproteinases. As a result, the ECM turnover, mainly the synthesis, overrides the degradation and results in fibrosis. What else we can have here is that we can have the activated hepatic stellate cells becomes a signal for the further activation of itself as well as for the hepatic cells. Now we have seen what happens in the normal condition, what happens in the liver after the injury. Two things to remember. What are those? First, you see the collagen, as I mentioned, change from type 4 to type 1 and type 3. Next is what? The proteoglycans, the glycosaminoglycans, like what are being secreted in the normal state is basically heparin sulfate. What is that? Heparin sulfate, main component of the basement membrane. But here what happens is that the hyaluronic acid, this is synthesized more. Along with it, we have the glycoproteins, fibronectin and laminin being secreted more than normal what it is used to be. Now, this ultimately leads to the development of fibrosis. And this fibrosis can be assessed by various sort of scoring, like Metavir scoring and Ishak scoring. So this basically so Metavir scoring and Ishak scoring. So I'm very much bit confused with the type handling this computer as well as this. So pardon me for that. So we have the fibrosis. If it is limited, portal fibrosis limited to few septa, we term it as F2. If it is only portal fibrosis, F1, no fibrosis, F0. And when the extensive septal fibrosis occurs, it becomes F4 and ultimately leads to cirrhosis. Advanced fibrosis, what it leads, it is ultimately makes the liver compromise in its function and results in the inability of the liver to perform its daily function with the liver failure, the ultimate stage, as well as cirrhosis, as well as hepatocellular carcinoma. And this is the common fate which you are going to encounter in any disease condition due to NFLD, AFLD, non-alcoholic, alcoholic fatty liver disease, as well as viral hepatitis. So we need to assess. We need to assess this fibrosis. Having said that, need to assess this fibrosis. The why question comes. Why? Why, Father, need to assess this fibrosis? Yes, we have to assess the fibrosis to stage the liver severity. In which stage it is, either it is in the F0, F1, F2, F3, F4, this stage. And with this stage knowledge, what we can do is that we can see that there are certain stages after that which is reversible, and beyond that which is irreversible. So this can also guide us in planning the treatment. Guiding treatment, if you are suffering from hepatitis B viral infection, you should be given right for an antiviral treatment. If you're suffering from NFLD, your metabolic control should be proper. So these all things has to be guided, and that treatment guiding treatment decisions are very well done by these markers. Monitoring treatment response, yes, whether treatment is working or not, if you have to just increase the dose or enhance the diet control and the metabolic control, this has to be done. Risk stratification of complication, yes, risk stratification of complications means what? Now, these hepatic failure cases can ultimately lead to hepatic encephalopathy. They can lead to cirrhosis. You can have portal hypertension with low platelet counts. So you can stratify which are all those patients, right, and which can progress to those complications. And at the last, you need to avoid unnecessary interventions. Unnecessary interventions, this is what I say, that previously when we had to assess the level of fibrosis, we need to do liver biopsy. So those unnecessary, like in the very beginning, no doubt liver biopsy is the gold standard, but yes, in the initial stage we can avoid, and this is what the requirement has arose. What is the limit of this liver biopsy? It is invasive, it is painful, bleeding occurs, long-term longitudinal monitoring. You can't just go on, right, taking the biopsy specimen and out the stage of fibrosis, whether it's progressed or whether it has regressed. You can't do that. Also, the sampling error. The fibrosis as a whole is a heterogeneous process, not homogeneous. So the point where you are taking the sample can be right. So the sampling error is there. Interpretation can be different from histopathologists, one person to other, and it's like not suitable for the longitudinal monitoring. That's what I said already. So there has come the need for an alternative. So the alternative which can be used, which can be patient compliant, more patient compliant, which is non-invasive, which allows us to longitudinally monitor, which allows us to facilitate large-scale screening, as well as which reduces the healthcare cost, as well as the time to diagnose. Now, what are the categories of these serum biomarkers we are speaking to? Now, before discussing this slide, we should remember from our previous slides, two important things were happening. One was the ECM turnover, the hepatic stellate cells were forming, and second was what? There was a dysfunction in the hepatic cells. So these are the two things. If you remember, these panels, these markers are going to be very much easy for us to understand. Now for the direct markers, we are having what? Which reflects the ECM extracellular matrix turnover. It is represented by these markers, direct markers, this hyaluronic acid, this laminin, the procollagen type 3. As I said, the type 3 supersedes the type 4, the type 1 and the type 3, the matrix metalloproteinases, the tissue inhibitor of matrix proteinases, the transforming growth factor, which was the fibrogenic signal. So these were all the direct serum markers. And the indirect one, which reflects the hepatic dysfunction, they are basically the ASTs, the ALTs, the gamma GTs, the platelets, the albumins. Now, let us quickly go through those direct serum biomarker and the indirect serum biomarker and understand the principles with examples. Though maximum of the part has been already discussed, just quickly I'll just pass through this slide. Hyaluronic acid, it is an extracellular matrix glycosaminoglycan, from activated hepatic stellate cells, and that is what we can measure, because this is the glycosaminoglycans whose synthesis increases, and that we have seen for the normal liver tissue it was heparan sulfate, and for abnormal after injury it is hyaluronic acid. Pro-collagen type 3 amino terminal peptide, because the type 3 collagen is been formed more. So if we can measure those pro-collagen type 3 amino terminal peptide, if we can measure this tissue inhibitor of matrix metalloproteinases, so we can just get a hint it relates with the level of fibrosis. And this inflammation and fibrosis, it also includes the alcoholic liver disease as well as viral and hepatitis, the cause behind it. So we can just monitor. The laminin, if we monitor, it gives us an idea of the perisinusoidal fibrosis. Similar for the convex, matrix metalloproteinases, all are there right, which can give us a hint of the fibrosis related to the extracellular matrix turnover. For the indirect serum biomarker, which basically gives us an idea of the liver function, the ASTs and the ALTs basically gives us the idea of the liver function. The platelets, the iron platelets basically gives us the idea about the portal hypertension, the sequestration. And this portal hypertension, why it develops? Because those hepatic stellate cells after injury, when there is a phenotypical change, I just missed that point. So there occurs a contraction. So that contraction will result in the resistance in the flow of the blood through the sinusoids. As a result, the portal pressure increases, and the portal pressure ultimately gets reflected as portal hypertension, and the spleen becomes enlarged in size, and it engulfs the platelets, the sequestration occurs, and you get a lesser platelets. Measuring bilirubin, albumin, INA gives you an idea about the synthetic function of the liver. So these are all the indirect biomarker that we use. Fine, we have discussed. So do we have any method to detect those markers? Yes, we do have. The direct markers, the number of direct markers that I have discussed can be measured through immunoassay techniques like ELISA, chemiluminescence, electrochemiluminescence, and the platform right fine basically nowadays they are providing our Siemens, Roche. For the indirect markers, these are all normal tests, regular tests that you do, and we use the routine photometric instruments. We use the immunoturbidometric method, nephelometric method, and electrical impedance. So these are the instrumentation that we have and the various platforms that we can use. Having said so, this individual marker, monitoring them individually doesn't carry any sense. That means it is not of that value. What is of value is that bringing them together, making certain sort of panels, and this is what is done. So we have a panel for the direct markers for this ELF, that is enhanced liver fibrosis, which has the components of hyaluronic acid, tissue inhibitor of matrix metalloproteinases, and the type 3 pro-collagen amino peptide. So these three components are taken together, and as you can see, there are a certain sort of calculations which is done, and ultimately a cutoff score which is there, right, fine, which decides whether that particular person has got the F2 level of fibrosis or F3 or F4 level of fibrosis, and that is basically 9.8 in this case. Then there is another panel which is Shasta. So it is the gender, sex, along with hyaluronic acid, HS stands for hyaluronic acid, and then AST and albumin. Now this all right when also takes into calculation, this component are taken into calculation, and a value of cutoff of around 0.3 leads you to the diagnosis, means staging of the fibrosis to be F3 or F4. There are certain other tests also, other panels also, like the fibro test, which takes into account the hyaluronic acid, both the direct and the indirect markers, and a value of around 0.74 gives you the fibro. So these all panels, what I am discussing is that you can see in the slide that they are relevant in various, means relevant disease to disease they vary. Like for ELF, it is very much useful for the NFLDs and the NASH. For SASTA parameter, the HIV and HCV related chronic liver disease, the fibrosis occurring right fan can be useful. And for the fibro test, it is the hepatitis B and hepatitis C related fibrosis. Now these are all direct panels. Coming to the indirect panels, we have got this APRI, which is your AST platelet ratio index. You have got this fibrosis index, which also takes into account the component of age, AST, ALT, and the platelets. We have got the NFLD fibrosis score, and we have got the BARD score, which takes into account the BMI and diabetes. So this all scoring system gives us a certain sort of cutoff value through which we can just assess the level of fibrosis. There are certain combined panels also which uses the imaging technique along with those markers. And with the imaging technique, we know this vibration controlled this transient elastography, right, which is basically used by the radiologist, that can be included into the panel to get a sort of certain sort of clinical value. Now we have discussed about the direct and the indirect. So the main points of difference were, one is for the ECM turnover, another is for the hepatic dysfunction. One examples for direct biomarkers were hyaluronic acid, P3NP, TIMP1, and for the indirect is AST, ALT, platelets. We use it as a panel. The panel for the direct markers are ELF, fibrotist, and for the indirect is APRI and FIFO. So all those panels that we have, which are those panels which are very much common and is in use? They are basically the APRI, the FIF4 for the indirect panels, and for the direct panels, this is an enhanced liver fibrosis test. Now the indirect panels are very much useful in the sense that they can be the initial screening tool, as they are cost effective and widely accessible, so we can just have a sort of utilize them for the screening purpose. The direct one, it gives a numerical ELF score that I have already discussed related with the fibrosis stage. It approved for the use in non-alcoholic steatohepatitis, and it is endorsed by NICE, American Association for the Study of Liver Disease, as well as the European Association. So they are endorsed. They are there in the clinical practice. So what are the clinical utility? So this interpretation ELF score, I'll just skip it. Coming to this clinical use guidelines. So you see we are taking into account the indirect panel as well as the direct panel, putting it into the algorithm flow chart, and we are deciding, right, fine, whom to refer to the higher center. So for a primary care setup, this becomes very much useful. For the FIF4 scoring, a patient who is having the risk factors very much there in him, we can just first start with FIF4 scoring. Cutoff of 1.3, less than 1.3, as you can see, we can use it to stratify it as low risk. And if it is greater than 3.25, then we can just say it to be higher risk. In between this 1.3 to 3.25, the intermediate zone where we can use the enhanced liver fibrosis panel, and this panel with a cutoff of 9.8, less than 9.8 or greater than 9.8, we can just decide whether the patient goes for the routine management in the primary care setup, just like managing the metabolic disease, managing the diet, taking care, and the routine screening around 1 to 2 years or 3 years interval. But if it is more than that, it goes with referral to the higher center where the further assessment for the complications and all is required. Similar, this is basically the Camden-Islington NFLD pathway. This is what is being used in the clinical practice, very much beneficial for the primary care practitioner. There are others also, right, fine, which are using, but the value of the FIF4 score differs a bit, but ultimately the bottom line is the same, that we can use this FIF4 along with ELF so that we can just screen the patient whom to refer to the secondary or the tertiary care center. Now this is a flow chart which basically is used which is endorsed by the American Association for the Study of Liver Disease. Here also you can see The FIB4 greater than 1.3, if it is less than 1.3, we can monitor them periodically. If it is greater than 1.3, right, it comes to the secondary level of assessment where we can use either the imaging technique or the enhanced liver fibrosis panel. In the imaging technique, as I said, vibration control transelastography is there. So we have got certain cutoff. With the cutoff, right, when we can further stratify. So if it is less than 9.8, then it again goes back to the level where it can be managed in the primary care setup, because the chance of fibrosis is lesser. But if it is more than 9.8, then it goes to the referral stage, and we refer the patients to the higher center, where further we can just do this magnetic resonance elastography as well as corrected T1. The low risk, the high risk further defined, and this intermediate zone in this particular secondary referral center is basically helped by the utilization of the liver biopsy. So we can see the method, diagnostic method, which was there historically, the primary diagnostic modality. Now we can use it, right, when only in the secondary, tertiary level care, right, when in the referral centers, when there is a sort of confusion because of the intermediate decision-making process, then we can use this biopsy to further stage the fibrosis. So this is what it is. So this is where we can do. So clinical use and guidelines are there that we have seen. FIB4 for the first initial screening step, and then ELF we include, right, when there is an intermediate range. Avoids unnecessary biopsies and informs patient management, referrals and therapeutic strategies also we can make it. There are lots of supporting evidences. There are lots of study being done with the negative predictive value, positive predictive values, defined sensitivity and specificity in various populations. It has found to be significant. Mainly, the high negative predictive value of this enhanced liver fibrosis for excluding cirrhosis is very much important for us and very much helpful for us. So we have seen and we discussed that the alternative marker that we were trying to find out whether the serum biomarkers worth it or not. So after this discussion of few slides, we can come to the point that yes, this alternative, which is given by the serum biomarker panels, is useful. Why it is useful? Because it is non-invasive, safe and reproducible. It can be integrated into routine blood work, suitable for serial monitoring, and it is available for the use of the primary care settings. This is where the utility is very much more in the primary care level, where the referral can be very much controlled, and referral can be very much properly optimized. Now, having said so, limitation and challenges are also there. What are the limitations? Yes, I have just 5 more minutes. So there is variability due to comorbid conditions. Yes, the inflammations can give rise to those like acute phase proteins like alpha-2 macroglobulin can rise. For the kidney disease, it can give a sort of variable levels of hyaluronic acid. So those comorbid conditions, if it is there, their utility is questionable. Limited availability of some biomarker, because these panels, what I have said you, they are the proprietary items for certain sort of diagnostic panels, diagnostic platforms like Siemens. ELF is their proprietary item. So you should have that Siemens machine to have that particular ELF panel to be done. And it requires validation, further validation in certain sort of other specific ethnic population as well as disease populations. So what is the emerging trend and future direction? Yes, we can integrate the biomarker with the imaging. We are doing it. Further we have to do. We can use artificial intelligence and machine learning like deep liver fibro-AI, which gives the algorithm to come to a diagnosis, and the treatment plan also is decided. Biomarker discovery further is going on. The omics technology, which is nowadays very much common and very much relevant. The transcriptomics, we are dealing with the microRNAs, the 22, which gives the liver dysfunction status, the microRNA 34A, which gives the hepatic stellate functions, the proteomics, the O-linked panels measuring the various sort of proteins, metabolomics, bile acids, and lipoidomics, and we have to develop the personalized fibrosis risk scores. Emerging panels. What are the emerging panels we have? We had type 3 pro-collagen amino terminal peptide, where we are just measuring the amino terminal part of the type 3 pro-collagen. Here, nowadays, there is a sort of try to find out the level of pro-collagen peptide, type 3 peptide. So pro-collagen type 3 peptide, this is the type 3 collagen, that is can be also measured. These are under trials. ADAPT is still in the validation phase, which uses AST, diabetes, platelets, and the ProC3. NIS4, which takes into account the microRNA 34A, hyaluronic acid, TIMP, and HbA1c, and there are liver. So emerging markers basically shift the focus from the static fibrosis staging to a dynamic ECM turnover, enabling earlier intervention and precision monitoring. So concluding the discussion for today, what we have seen is that serum biomarkers are the cornerstone in non-invasive liver fibrosis assessment. Enhanced liver fibrosis test is robust, evidence-based, and has got a very good clinical utility whenever there is a sort of indeterminate phase, indeterminate sort of results. Adoption of biomarker strategies enhances patient care and reduces obviously the biopsy reliance, and future research will refine and expand their applications. Thank you.
So extensive presentation involving features of liver and cellular functions, remembering our earlier days of basics of medicine. And these things are chemistry based, obviously, and chemistry is involved in every cell, everywhere, starting from the membrane, inside and outside the membrane. So extracellular matrix is the important issue here. And Dr. Indrajit nicely compiled all the pathophysiological features in different stages, the cellular functional mechanisms, and he explained in detail the development of the fibrosis process and the different markers arising thereof to make us understand the importance of going for such investigations, which are, I hope, to be adopted at different centers around us, even I hope at this college also in some time to come. And just I understand that we have to go forward with these ideas. We cannot live with what we have learned so far so long. So it is Dr. Indrajit who enlightens us, and it looks difficult, it seems difficult at every step of his presentation to grab the things, to assimilate the things, and but we have to go with this. I am very proud of Dr. Indrajit in the sense that I had the experience of working with this young postgraduate from his inception days at North Bengal Medical College, and now he is working in a higher platform. So I hope there may be some questions from the audience.
Thank you, sir. Thank you.
If you feel free, you can come up, and he is ready to explain you again the difficult areas?
I think it's pre-lunch time, so all are somewhere right when interested. More, yeah, please, sir. Yes, sir. They are available. They are available in various centers, the enable accredited labs, like the LAL pets and all. So they are very much available. Now, as I said, like the indirect marker panel, so that doesn't require any sort of extra things. The routine test, whatever you are doing, right, when you can incorporate, like the APRI score, the FIF4 score, you can incorporate, you can calculate, and you can find out. Yes, to have a sort of entire, like sort of a diagnostic algorithm, you need to introduce the ELF also, like those direct marker panels. Yes, they are available in the sense that you can do it through ELISA, but you have to have those calculations, which are there very much the proprietary item. So the Siemens platform, like the Advias and UCP and all those machines, the Roche's machines, right, they are giving it, they are providing that.
So cost, how much it costs?
Sir, that is not known to me, okay. But it is affordable, and it is less only as compared to the other investigations. If you go for the imaging one and all, right, so it will be lesser than that.
Thank you, thank you.
Any more questions from audience side? No, then we have to conclude. Thank you, Dr. Njit. You have presented nicely for our largest organ of our body. And I am pathologist. Biopsy is the gold standard, but imaging and biochemistry replaces that. That biopsy is a very tough thing and also painful and costly. So these are good. We have to follow that. Thank you.
Thank you, sir. Thank you.
Thank you, sir, for such an engaging presentation. Now, I would like to request Professor Dr. Tapan Mukherjee, sir, and Professor Dr. Sanjay Kumar, sir, to felicitate our speaker. I would like to request Professor Dr. Indrajit Nath, sir, to come on stage for felicitation. Now, I would like to request our speaker, Dr. Indrajit Nath, sir, to felicitate our chairpersons. Thank you, sir. The next topic for today's session is hematopathology is the backbone of hemato-oncology. Perspective of a hemato-oncologist will be presented by Dr. Avinash Kumar, sir, Director, Hemato-Oncology and BMT, Paras, HMRI, Patna. I'd like to request Avinash Kumar, sir, to kindly come on stage.
Next, I would like to request Professor Dr. Swapan Ray Sir, Professor, Department of Pediatrics, MGM, and Professor Dr. Barnik Chaudhary Sir, Professor and HOD, Department of Pathology, JMN Medical College, Chakda, for chairing the session. Thank you.
They must have shared. Hello, hello. So, good afternoon. So we are between the lecture and the lunch, but we have got a very good faculty, Dr. Avinash Kumar Singh. He is MD and DM Clinical Hematology of AIMS New Delhi, and he is the Director and HOD of the Hematology, Hemato-Oncology and the BMT. He works in the Paras HMRI Hospital, KHEF, and the Padna Hematology Clinics, Padna BR. And he has got many feathers on his cap, like the Honorary Treasurer, ISHBT, EC member of the EHG, and the Secretary HFB. So without any wasting time, sir, it is the time to listen to you. So, good afternoon, everyone. Thank you, respected chairperson, for kind introduction. And first of all, I would like to thank organizers, INVESTICON 3, for including me in this prestigious conference. And it's quite learning for me. Since morning, I have attended all the lectures and they're excellent. And I'm a bit scared because I practice in a private setup and I don't have any experience of teaching students. So all the faculty who have presented, they are from teaching institutes. They have lots of experience. And special thanks to Professor Asitawa, who is my friend, and we have some common link. We are from Guwahati Medical College, Guwahati. I did my MD medicine from there. Dr. Ashok and Dr. Avinash Priyadarshi, Dr. Ernest Tiwari, Dr. Sarath, and all the hospitality which they shared. I just want to say thanks. And my regards to all the faculty from MGM Medical College, and love and blessings to all the students who are here. So the topic is hematopathology is the backbone of hemato-oncology practice. So it's a well-established fact that the practice of a hemato-oncologist or hematologist, it depends upon an able hematopathologist, a transfusion specialist, and obviously some infectious disease specialist or microbiologist. So these three are pillars. So I just want to say that our practice wholly depends on them. So for this presentation, for about 20 minutes, what I am going to share, first 1, 2, or 3 slides are what I have learned in my last 15-20 years of my experience as a clinician, and then I would share some cases, learning cases, and I would request all the PG students to participate without thinking that they are from pediatrics, they are from pathology, microbiology, biochemistry, radiology. They should participate. So the learning, my learning, it's not moving? Okay, okay. I think we all should know what is health. So health doesn't mean physical body. If you see the definition of WHO, so health is defined as physical, mental, emotional, social well-being. And many times we forget all the 3 components. We are just concentrated on the physical health. And that's why what happened, as a doctor, we have become like policemen. Policeman जिसका काम होता है चोर को पकड़ना. तो जैसे हम लोग ना कोई एक एक चीज़ बैठते हैं कि भाई वी हैव टू डिटेक्ट हाइपरटेंसिव्स, बीपी के मरीजों को पकड़ना है. But the role of policemen is to protect, to create environment where there should not be thieves, there should not be any problem. So as a doctor, it's our responsibility to teach our people how not to become diseased. And the role of lifestyle is very important. We all have our own lifestyles. We are about, suppose 50 people sitting here, all have different lifestyles. Many a times what happens, the book or the paper that we read are from a population where lifestyle is different. And as a clinician, when we practice in a particular district or a state, the lifestyle of population is different. If we are biased, that okay, this is the BP, above that patient becomes hypertensive, we will wrongly diagnose many people, normal people, as hypertensives, and we are, as a doctor, we have become like dawai likhne wala aadmi ya jaanch likhne wala aadmi. Many times we will start telma, amlosave without considering why someone's BP has fluctuated. It's very important. So we have to understand the lifestyle. Then there may be abnormal lifestyle. So there can be healthy lifestyle, there can be unhealthy lifestyle. So unhealthy lifestyle doesn't mean disease. We can correct them, we can teach them that, okay, this is unhealthy, you can come to a normal, healthy lifestyle and you will not become diseased. Addictions are very important to address to people, that these are addictions, you should avoid it. I would like to request all students who are sitting here, if you have any addictions, please don't do it. Because as a doctor, you are role model in society. If you smoke and if you tell your patient that please don't smoke, it will have no effect. It will have no effect. You will lecture them for half an hour. It will have no effect. So you take alcohol, you can't tell people don't take alcohol. It can lead to CLD, portal hypertension and cirrhosis. It will have no effect, sure. You are just teaching them. So you should have addiction free as a doctor. And when a healthy lifestyle becomes unhealthy lifestyle, then the disease happens. It's not that from first time there will be disease. Whenever we encounter a patient, whether as a pathologist, as a biochemist, as a radiologist, we have to have patience. It's very important. Very important. Doctor word has come from dossier, to teach. We have to teach people that how they can have healthy lifestyle. It's very important. So as an MBBS, whatever specialty or super specialty you have, always throughout the life you become like a MBBS. So history is very important. History is like a biopic that you enjoy in theaters. Milkha Singh aap logon ne dekha hoga. So there is a story of Milkha Singh, how he became Milkha Singh. Just like that, every human being, if he has unhealthy lifestyle or if he has become diseased, he has a story to tell you. You have to listen that. So history and all the components of history that we have learned in third year teachings are very important to notice. Then comes the general examination and systemic examination that we also do. And after listening to history, we should have some impression that what could be the cause of a particular problem. Then we can have differentials, and then comes the role of investigations. So as a doctor, we have to choose investigations very wisely. Even as a first year clinician, first year PG students, we have to have reason why we are writing CBC, why we are writing peripheral smear. So American Society of Hematology has campaign, choosing wisely campaign. You have thousands of tests, how will you choose 2 or 3 which are very important? And so think twice before ordering tests. And then comes the role of treatment, whether my patient who is sitting in front of me requires treatment or not. There are many people who are suffering because of our treatment rather than because of disease or unhealthy lifestyle. Now coming to the topic proper. So as a hematologist, we see anemia, we see cytopenia, we see hematological malignancies. And anemia is important because 50% of our populations, they are anemic. We are teaching this for last about 40-50 years that 50% of populations are anemic, but still the anemia burden has not come down. The only reason is because of our mindset. We don't respect anemia as a problem. Many times, many doctors, they come with their family, with their wife, and they say that my wife's hemoglobin is 8, and maybe 8 is normal for her because it is for 20 years. But whatever is lower than normal is abnormal. We have to look for cause. It's very important. So we all do CBC, complete blood count, and the CBC looks like this. So CBC gives you lots of information: hemoglobin, WBC, platelets, differentials, MCV. They can give you thousands of information and clues by which you can have many impressions that what could be the cause of anemia in this patient. And even as a specialty which are non-clinical, you have to look at patients, whether there is pallor or not, icterus is there or not, how is the splenomegaly, bleeding signs are there or not. It's very important. And then comes the investigation. So CBC is the first test whenever you have problem of cytopenia or any hematological problem like leukocytosis from outside. Peripheral blood smear examination is important. Then comes the reticulocyte count. Now I would discuss 3 or 4 important cases. So the hypothetical 10-year-old boy who had history of recurrent epistaxis. 10 साल के बच्चे को बार बार नाक से ब्लीडिंग हो रही थी, and he also had history of skin bleeding. Ecchymotic patches बनते थे. There was no past treatment or family history which was significant, and this was the complete count. If it is visible, hemoglobin was low, low MCV, MCH, normal WBC platelets, differentials were normal. So this was microcytic hypochromic anemia. So now tell me, anyone can say, what are the common causes of microcytic anemia? Yes, any other? Yes. Very good, very good. Yes, yes, yes. So there are many causes of microcytic anemia. It's not only iron deficiency anemia, though the iron deficiency anemia is the commonest cause of microcytic anemia. We all should remember that. So these are all as Dr. Tiwari has said. So what happened to that patient? उस 10 साल के बच्चे को, he received 2 units of blood transfusion and tranexamic acid to control bleeding. ENT opinion was taken. There was no local cause. Advised to follow up in OPD. But even after 2 months, his epistaxis continued. He was admitted with severe anemia. Again, PRBC was transfused. He was advised to take good nutritious diet. Any other things comes in your mind? What next we should do? Yes. So coagulation profile we can do, but where he was evaluated, only the anemia part was being taken care of. So frequently he was requiring blood transfusion, oral iron, tranexamic acid, and this time someone has many times, even bone marrow was done. Bone marrow was done, and bone marrow was done from external puncture, and he started bleeding from external puncture. And at that time, after that, someone thought that there could be some bleeding problem. And then the bleeding was evaluated, PT-APTT was done, and all were normal. Any other things comes in your mind? What could be the possibility? PT-APTT was normal, platelets were normal, and he was bleeding. Epistaxis, skin bleed, and bleeding from puncture sites. Any guess? Yes. So platelet function defect is a possibility, and platelet function test was done, and he was confirmed as Bernard-Soulier syndrome. So message is, whenever you see cytopenia or anemia, look for cause of anemia. Throughout the world, only 3 causes of anemia are there. Either it is loss, it is breakdown, or reduced production. Look for cause of iron deficiency anemia. If you have iron deficiency anemia, don't consider IDA as diagnosis. It's IDA under evaluation, why someone has developed IDA. Look for cause of bleeding. If someone has menorrhagia, what is the cause of menorrhagia? Early age we take it as pubertal menorrhagia. But all doesn't have pubertal menorrhagia. There may be VWD, there may be platelet function defect, there may be ITP, we need to evaluate them. So next question is, name one test which you will order for anemia. Yes, so it's anything? For an anemic patient, name one test that you will order. What? Ferritin. So it was out. So ferritin you will do, because throughout the world only two types of anemia we see. One is iron deficiency, other is non-iron deficiency. So iron deficiency, if we have to rule out, do serum ferritin. Why serum ferritin? Because it will tell you that whether patient has iron deficiency anemia or not. Even if there is no anemia, it will tell that storage is there or not, okay? So serum ferritin is very important. Serum ferritin less than 30, it is iron deficiency anemia, classical iron. If suppose it is more than 30, then what are the causes? If suppose serum ferritin is more than 30, then what are the causes? Infection, inflammation, iron overload, anything else. In our society, if a patient comes to MGM Medical College and ferritin is more than 30, what could be the cause? In our society, in our villages, whenever someone has anemia, patient receives IV iron. So that is the most common cause in our setup, that you have to remember. Prior use of IV iron, that is not written in Harrison or in your textbook. You have to see. Many patients, they receive IV iron, only then they come to you. So you have to remember. Then come inflammation, infection, iron overload, primary, secondary, etc. Now comes second case. 40 years old male who had fatigability, low-grade fever, mass left hypochondrium for 6 months. He received 2 units of PRBC, and he had pallor and massive splenomegaly. There was no lymphadenopathy and no icterus. What are the causes of massive splenomegaly? Pardon? जोर से बोलो. हाँ? इन्फेक्शन तो 1000 चीज हो गया ना. मलेरिया में मैसिव स्प्लेनोमेगाली नहीं होता है. यस, वेरी गुड. कालाजार. तो कालाजार पहले होता था, अब कम आ रहा है ना, केसेस कम आ रहे हैं. कालाजार. देन कम्स PMG is wrongly written. It's primary myelofibrosis. Primary myelofibrosis. Then CML में massive splenomegaly हो सकता है, and sometimes CLD portal hypertension can have massive splenomegaly, and there are other causes like CLPD, splenic lymphoma होगा, उसमें भी massive splenomegaly होगा. And this patient CBC, you look, severe anemia, 4.2 hemoglobin, leukocytosis, thrombocytosis, क्या हो सकता है? इसको क्या हो सकता है? 40-year-old male who is having pallor and massive splenomegaly, and this is the CBC. What are the possibility? There is no fever, low-grade fever. It's not Kalajar. Yeah, look at this peripheral smear. Look at peripheral smear. इसमें क्या है? Yes, leukoerythroblastic blood picture. क्या हो सकता है? Very good, very good. So this is the biopsy. You see fibrosis, na? Fibers are there. To confirm primary myelofibrosis, or no, not to confirm, but to add on, what other test you will order? For primary myelofibrosis, what other test you will order? JAK2 mutation. JAK2 mutation is present in 50% of cases. So myelofibrosis, whenever you see myelofibrosis, it could be primary or it could be secondary. So primary myelofibrosis is a malignancy. ये blood cancer है. Secondary myelofibrosis we can get in infections like HIV, मेटास्टैटिक डिजीज, इस तरह की किसी बीमारी में मिल सकता है. Now coming to third case, 18-year-old girl who presented in casualty with weakness for 4 months, and this is the CBC. CBC में क्या दिख रहा है? So there is pancytopenia, and how much is the MCV? Yes, so it's macrocytic pancytopenia. 18-year-old girl, weakness, came in casualty with severe anemia, and she had knuckle hyperpigmentation. Knuckle hyperpigmentation, black discoloration tha. Retic was low, LDH was high, DCT, ICT was negative. What is the possibility? Very good. Tell me commonest cause of macrocytic anemia. Very good. And best way to exclude B12 folate deficiency is to give, don't do B12 folate level, that can mislead you. Give therapeutic trial with vitamin B12. 1000 microgram of vitamin B12 after a skin test, IM on alternate day. 7 injections. If it is B12 deficiency, patient will have improvement. If it is not, even if your B12 is less than 100, it's never megaloblastic anemia. So that is the best trial. 50 rupees B12 injection will confirm whether it is B12 deficiency or not. And do a skin test before B12 because there can be anaphylactic reaction and patient can die. So all pancytopenia are not due to serious disease like plastic anemia or MDS. Tell me one thing, malignancy and megaloblastic anemia, what is common? No. I am asking that megaloblastic anemia and malignancies, what is common? One thing, which is scary. Many patients of megaloblastic anemia, they refer to us thinking that it could be malignancy. What is one parameter which create problem? जोर से बोलो. So megaloblastic anemia is the only benign cause where LDH can be very high, 4000, 5000. हाँ? So बहुत सारे labs से जब panel होता है ना, LDH is very high, people think कि malignancy होगा, it's megaloblastic anemia. So that is all. 14-year-old girl presented with recurrent jaundice, positive family history, CBC. What is there in CBC? Hemoglobin is 11.5. TLC, DLC platelets are normal. What is there? Huh? क्या है? We have to develop habit. So MCV देखना है always. MCV is very low. With 11.5 hemoglobin, MCV is very low, na? So what could be the cause? आयरन, अपने माइंड को आयरन से हटाना है ना. जॉन्डिस हो रहा था बार बार ना. सो वेरी SPLC वाज डन, इट्स थैलेसीमिया माइनर. व्हाई दिस पिक्चर? हम लोग थैलेसीमिया डिस्कस कर रहे थे, ये पिक्चर क्यों आया? ये क्या है? सी है ना, सी. थैलेसा फ्रॉम सी. हाँ, पहले सीसोर पे ही थैलेसीमिया के पेशेंट्स थे, अब ये स्पोरेडिक हो गया सब जगह. Why this picture? They all celebrities having thalassemia minor. ठीक है? So 2 thalassemia minor can have thalassemia major child like this diseased child. So आज के बाद से कहीं भी आप लोग जाइए thalassemia minor को detect करना है. If both partners are thalassemia minor, during 3rd to 4th month we need to do fetal screening whether they are having thalassemia major or minor. If it is major, MTP should be done. If it is minor or normal, it should be continued. Always counsel every thalassemia minor that you are encountering. Detect thalassemia minor. It's very important. Many patients, both parents, they are doctors, pediatricians. Their first child has become thalassemia major. It's unawareness. So in every meeting, I just present this. If suppose, if HB, HPLC and iron level are normal, इसी बच्चे का, इसी पेशेंट का आयरन नॉर्मल, HPLC नॉर्मल, तो आगे क्या करेंगे हम लोग? माइल्ड एनीमिया, रिकरेंट जॉन्डिस, MCV लो, आयरन नॉर्मल, HPLC नॉर्मल, आगे क्या करेंगे? क्या बोल दो, जोर से बोल दो भाई. तो समटाइम्स वी बिकम बायस्ड. बीटा थैलेसीमिया, अल्फा को भूल जाते हैं. अल्फा थैलेसीमिया भी होता है ना. So we have to do mutation for alpha thalassemia. HbHPLC will not detect alpha thalassemia. It's important. अब suppose ये लड़की 18 साल की जिसको थैलेसीमिया माइनर है, सी ए स्टार्टेड रिक्वायरिंग ट्रांसफ्यूजन, थैलेसीमिया मेजर की तरह बिहेव करने लगे, तब क्या करेंगे? उसका HPLC आया था थैलेसीमिया माइनर वाला एंड सी इज रिक्वायरिंग एवरी मंथ ट्रांसफ्यूजन, तब क्या करेंगे? क्या हो सकता है उसको? थैलेसीमिया माइनर यूजुअली डजंट रिक्वायर ट्रांसफ्यूजन ना? क्या क्या HBE के जोर से बोलिए मैडम। नहीं, E रहेगा यदि तो HPLC में आ जाएगा। A2 लेवल विल बी वेरी हाई। इसका A2 आया नॉर्मल, माने नॉर्मल मीन्स माइनर रेंज में 4.5 5.9 समथिंग, और उसको ब्लड चल रहा है, आयरन नॉर्मल है। जल्दी जल्दी बताइए, लंच लेट हो रहा है। हाँ, एक अल्फा ट्रिप्लिकेशन होता है, अल्फा ट्रिप्लिकेशन। थैलेसीमिया माइनर को यदि बार बार ब्लड चढ़े तो सस्पेक्ट अल्फा ट्रिप्लिकेशन, उसके लिए म्यूटेशन स्टडी कराइए, ठीक है। एंड इनकरेज वॉलंटरी डोनेशन। वी हैव लॉट्स ऑफ थैलेसीमिया मेजर चाइल्ड। 14 जनवरी वाज वर्ल्ड ब्लड डोनर डे। आप लोग जितने बच्चे हो सब लोग डोनेट करो ब्लड एवरी 3 मंथ। आई डोनेट, देयर इज नो प्रॉब्लम, बहुत बहुत अच्छे उसके बेनिफिट हैं। सो ऑलवेज डोनेट, आज नहीं तो कल जाके डोनेट कर देना, हार्डली इट टेक्स 5 मिनट्स टाइम। वी कैन प्रिवेंट थैलेसीमिया and no child with thalassemia major should born. एक केस है, मे बी इट्स लास्ट केस, 26 years old pregnant lady presented with anemia requiring transfusion for 2 months. प्रेगनेंसी था और she was requiring transfusion, हर महीने ब्लड चढ़ रहा था उसको। There was no lymphadenopathy or organomegaly and see the CBC, there was pancytopenia with normal to high MCV. क्या हो सकता है? Sorry, I have written it's aplastic anemia. It's very common in our this one. Aplastic anemia can be acquired or inherited. Acquired adults में ज़्यादा है, inherited जो है बच्चों में common होता है। Acquired aplastic anemia, if patient is 40 साल से छोटा हो तो bone marrow transplant करना चाहिए। More than 40-year-old, immunosuppressants are the treatment options. Now again some question. Name one test which confirms aplastic anemia. एक टेस्ट बताइए जो aplastic anemia को confirm करेगा। नहीं, बोन मैरो नॉन स्पेसिफिक होता है। एज ए पैथोलॉजिस्ट वी शुड नॉट से बोन मैरो करेंगे। वी हैव टू सी, बोन मैरो एस्पिरेशन करेंगे, बोन मैरो बायोप्सी करेंगे, क्या करेंगे कंफर्म करने के लिए। यस, वेरी गुड। सो बोन मैरो बायोप्सी इज मस्ट फॉर डायग्नोसिस ऑफ एप्लास्टिक एनीमिया। व्हाट इज नॉट सीन इन एप्लास्टिक एनीमिया? एप्लास्टिक एनीमिया मरीज में क्या नहीं मिलता है? स्प्लीन, लिम्फेडेनोपैथी या दोनों नहीं मिलेगा? हाँ, नो ऑर्गेनोमी, वेरी गुड, वाह बहुत अच्छा। सो यू विल नॉट गेट, देखो क्लिनिकल डिक्टम है, इफ यू गेट स्प्लिनोमेगैली एंड पैनसाइटोपेनिया इट कैन नेवर बी एप्लास्टिक एनीमिया। सो व्हाई एप्लास्टिक एनीमिया इज डेंजरस? हाँ, सो MDR infection and IC bleed, life threatening bleeding. What should never be given to a patient of aplastic anemia? As a clinician, in prescription, you should never write one drug or one group of drug. क्या नहीं देना चाहिए? जोर से बोलिए। हाँ, NSAID नहीं देना है। Platelets are very low ना, they will die. They will not die because of 10,000 platelet, but Dilona दे देंगे दर्द के लिए ना, they will die for sure. Avoid NSAIDs. Then comes 78 years old male, थोड़ा सा 5 मिनट, हाँ ठीक ना। So weakness and back pain, and this is the CBC. CBC showed mild anemia, TLC, DLC platelets are normal. Look at this X-ray and tell me the pathology. Identify the pathology. इस X-ray में कहाँ दिक्कत है? बोलिए बोलिए, जल्दी बोलो। बोन में है कि हृदय में है कि फेफड़ा में है, कहाँ दिक्कत है? वाह, वेरी गुड वेरी गुड। सो समटाइम्स माइनर क्लूज बेड साइड जो पहले से किया हुआ टेस्ट है, ऑलवेज हैव हैबिट ऑफ लुकिंग एट दीज थिंग्स। एक्सरे देखिए, यू विल हैव समथिंग। सो नाउ टेल मी व्हाट टेस्ट यू विल डू टू डायग्नोज मल्टीपल माइलोमा। सस्पेक्टेड माइलोमा आपके पास रेफर हुआ, व्हाट टेस्ट यू विल डू? क्या यस क्या एचबी इलेक्ट्रोफोरेसिस, एचबी इलेक्ट्रोफोरेसिस, वाह वाह, वेरी गुड वेरी गुड। सो बेंजोस प्रोटीन जो है पुराना टेस्ट था, उसको नहीं करते हैं। सीरम सबसे पहले तो रूटीन टेस्ट करेंगे, देन सीरम प्रोटीन इलेक्ट्रोफोरेसिस, सीरम फ्री लाइट चेन रेशियो, इम्यूनोफिक्सेशन, यूरिन एनालिसिस, बोन मैरो एस्पिरेशन बायोप्सी, फिश स्टडीज, एमआरआई, पेट सीटी वी कैन डू। इन केस ऑफ माइलोमा व्हाट टू अवॉइड, ये बताइए। किसी को माइलोमा हो सकता है, देन एज ए डॉक्टर आप क्या कहिएगा कि ये चीज मत करना भाई? एक चीज कॉमन है, एनएसएआईडी नहीं देना है, नेफ्रोटॉक्सिक होता है ना, एनएसएआईडी नहीं देना है। डिहाइड्रेशन अवॉइड करना है, पानी कहना है खूब पीने के लिए, बिकॉज डिहाइड्रेशन कैन लीड टू रीनल डिस्फंक्शन। एनएसएआईडी नहीं देना है, नेफ्रोटॉक्सिक ड्रग नहीं देना है, ट्रॉमा अवॉइड कराना है बिकॉज दे कैन हैव फ्रैक्चर। सो इनको माइलोमा डायग्नोज हुआ था। माइलोमा community globally is dominated by Indians. You students, if you have any interest in hemato-oncology, hematopathology, you can do super specialization in hemato-oncology. You can go to US. जो भी world leader myeloma के हैं, they are from India. M से treat हुए, CMC वेल्लोर से उनका training हुआ, they are now world leader. 14-year-old boy presented with gum bleeding and epistaxis for 7 days, history of low-grade fever 7 days back, no lymphadenopathy or hepatosplenomegaly, and other tests were normal. Look at CBC. Hemoglobin is 8.5, MCV थोड़ा कम है, platelets बहुत ज़्यादा कम है, TLC, DLC नॉर्मल। क्या हो सकता है? हाँ, ITP ही होगा क्या? Most probable diagnosis क्या क्या हो सकता है? 14-year-old boy who is having skin bleeding, सीवियर थ्रोम्बोसाइटोपेनिया, माइल्ड एनीमिया, स्प्लीन नहीं है, लीवर नहीं है, क्या हो सकता है? क्या क्या हो सकता है? पोस्ट वायरल हो सकता है, लो ग्रेड फीवर की हिस्ट्री थी, पोस्ट वायरल थ्रोम्बोसाइटोपेनिया होता है। आप कहिएगा कि नहीं होता है, बिकॉज आफ्टर वायरल इन्फेक्शन वी डोंट चेक सीबीसी। जिनका करते हैं उनका 70,000 आ जाता है, 60,000 आ जाता है। आईटीपी हो सकता है, एक्यूट ल्यूकेमिया हो सकता है, ALLs हो सकते हैं। इट्स इंपॉर्टेंट। और ब्लाइंडली यदि आप आईटीपी सोच के ALL को स्टेरॉइड दे दीजिएगा, दे विल गो इनटू टेम्पररी रिमिशन और बाद में रिलैप्स होगा। सो ऑलवेज मेक श्योर दैट इट्स आईटीपी एंड नथिंग एल्स, ओनली देन स्टार्ट स्टेरॉइड। प्लास्टिक एनीमिया भी हो सकता है। So whenever there is thrombocytopenia, this is good algorithm that you should follow. First check peripheral smear whether it is true thrombocytopenia or pseudo thrombocytopenia, and look at smear findings and then diagnose. No need to take photograph, you can take slides, हाँ, कोई दिक्कत नहीं है। What drugs to avoid in ITP? Again it's NSAID, हाँ। Name few NSAID. अब आप लोग बताओ कुछ NSAID ड्रग का नाम बताइए। क्या? Very good. जल्दी जल्दी बोलो। यस, इमरजेंसी में सबसे ज़्यादा डायलोना यूज होता है, तो वहाँ रोकना है लोगों को कि भाई नहीं यूज़ कीजिए। सो डायलोना, ब्रूफेन, नाइस, कॉम्बीफ्लैम। व्हाट इज़ नॉट देयर इन आईटीपी? आईटीपी में कुछ नहीं मिलेगा क्लिनिकली, जैसा वो डिस्कस भी किया, इस बच्चे को नहीं था। क्या नहीं था? यस यस, स्प्लिनोमेगैली, लिम्फेनोपैथी बोथ। नो स्प्लिनोमेगैली। डोंट फॉरगेट टू रूल आउट HIV. HIV in 10% of cases can present only with thrombocytopenia, no fever, no constitutional symptoms, no weight loss, and many a times HIV सबका हो जाता है, लेकिन sometimes we miss, तो करना है। What diet you will suggest to increase platelet count? ये सबको आंसर करना है। ऐसा क्या डाइट आप किसी पेशेंट को बताएंगे जिससे प्लेटलेट बढ़ेगा, क्योंकि सब लोग यही पूछेगा। कौन सा डाइट है जो आप बताओगे? हाँ, और क्या? सो जो भी आप बता रहे हो ना, ये सब मिथ है। इट हैज गॉट नो साइंटिफिक एविडेंस दैट पपाया एक्सट्रैक्ट, कीवी फ्रूट दे हेल्प। सो नेवर 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 मत दीजिए। इन आईटीपी पीपल सफर ड्यू टू, आईटीपी पेशेंट क्यों सफर करते हैं? बोलिए। नो नो नो, इन ब्लड देयर इज एन आर्टिकल हाउ आई ट्रीट आईटीपी। उसका जो पहला लाइन है वो लिखता है कि इन आईटीपी पीपल आर सफरिंग मोर बिकॉज ऑफ आवर ट्रीटमेंट रेदर देन बिकॉज ऑफ थ्रोम्बोसाइटोपेनिया। सो इट्स वेरी इंपॉर्टेंट। हाँ, हड़बड़ी में नहीं रहना है कि प्लेटलेट बढ़ा ही देना है। देयर आर मेनी पेशेंट्स हु इज अंडर माई फॉलोअप हु आर हैविंग 10,000 प्लेटलेट फॉर लास्ट 10 years, नो प्रॉब्लम। we have tried some medicines, it's not working, so patient has decided कि आपका treatment बहुत toxic है, हम आपके यहाँ follow up में आएंगे, but I don't need treatment. So in ITP, people are more suffering, yes? Platelet transfusion is needed in ITP, yes or no? हाँ? क्यों? हाँ. आप लोगों को क्या लगता है, प्लेटलेट देना चाहिए या नहीं? अच्छा नहीं, कभी नहीं देना है. 10,000 के नीचे होगा तो क्यों दीजिएगा? नो, नहीं होगा इंटरनल हेमरेज. देयर इज ए साइंस बिहाइंड दैट. So in ITP, platelet transfusion is indicated only if there is massive ongoing bleeding. Massive ongoing bleeding. अब आप कहिएगा कि 10,000 के नीचे था, आप प्लेटलेट नहीं दिए, इसी कारण से ongoing bleeding हुआ. आप लड़ सकते हो, बट एज ए डॉक्टर वी शुड हैव सम कॉन्फिडेंस कि भाई ऐसा नहीं होता है, वो प्लेटलेट देने से बीमार पड़ेगा ज़्यादा. एंड देयर इज अ साइंस बिहाइंड दैट. 5,000 प्लेटलेट है, बट वाट एवर प्लेटलेट्स आर देयर, दे आर नैव प्लेटलेट्स. वो अभी बन के बोन मैरो से निकले हैं. दे आर हीमोस्टैटिकली एक्टिव. आप सिस्टर को देखो, उनको कैनुला लगाते हुए ब्लीडिंग नहीं होती है. किसी हीमोफीलिया पेशेंट को देखो, कैनुला लगाते हुए ब्लीडिंग बहुत ज़्यादा होगा. सो इट्स इंपॉर्टेंट टू अंडरस्टैंड. अदरवाइज हम डर जाएंगे ना कि बाप रे 5,000 प्लेटलेट वाला आया है ना, तो गार्जियन जो है वो तो 15-20 लोग आया है, वो तो और घबराया हुआ है, वो तो कहेगा जल्दी प्लेटलेट चढ़ाइए. सो वी हैव टू बी वेरी श्योर इट्स नॉट रिक्वायर्ड. एंड देयर इज ए स्टोरी अबाउट ITP. एक थे डॉक्टर थे, ही वॉज वर्किंग ऑन प्लेटलेट्स. व्हाट ही डिड, इस रिसर्च से पहले हम लोगों को पता नहीं था कि देयर इज ए इम्यून प्रॉब्लम इन ITP. सो उन्होंने क्या किया, अपने ब्लड ग्रुप के एक ITP पेशेंट को लिया और उनका सीरम 500 ml अपने में इंजेक्ट कर लिया. एंड इन जस्ट फ्यू आवर्स ही डेवलप्ड सीवियर थ्रोम्बोसाइटोपेनिया. एंड दैट प्रूव्ड दैट देयर इज ए इम्यून पैथोजेनेसिस बिहाइंड ITP. ठीक है. If you have interest in hematology, you can become member of these societies, Indian societies, international societies. जैसे INVESTICON है, you can participate regularly. We have Hematology Foundation of Bihar. We do Rakt Vigyan every year, so you can join that, you can learn. I invite all of you for Rakt Vigyan 7 that is scheduled on 23rd and 24th August. And all great faculties from all parts of India, from Kolkata, Mumbai, Delhi, Vellore, they will come, they will speak on common topics. You can learn, you can get inspiration from them. And this is a complimentary for today, that if you are interested in joining this event, we will have 0 fee for registration. But you have to tell me by today 7 or 8 p.m. So tomorrow it is applicable, you will have to pay fee. And whoever are from Kishanganj or faculty from this place only are eligible. You don't have to name your colleagues from PMCH, NMC or something like that. Huh? So one person can collect all the names, can share on my WhatsApp, and that is free. You can join. So thank you everyone. And thank you everyone. I have just one request. After lunch, we will have 10-minute session on heartfulness meditation. So I would request all of you to join. There is no PPT, no headache. साइंस नहीं है, hematology नहीं है. उसमें हम लोग मेडिटेशन के बारे में डिस्कस करेंगे और ध्यान करेंगे 5-10 मिनट. तो खाने के बाद आ जाना है. थैंक यू.
Thank you, Dr. Singh. If you have got any questions, because I think a lot of questions should be there, but lunch is waiting for you. So if you don't have any question, let me ask you, sir. It's a real patient in our ward. Dr. Ashitabo knows it very well. We have got a patient of mucolipidosis type 1, suffering from pancytopenia. We are in a real soup. So what can be the explanation? Because you are expert in bone marrow transplantation, and we have done bone marrow also. Can you give us any clue why it has occurred?
Yes, sir. So that is confirmed mucopolysaccharidosis?
Yeah. It's a genetically tested and confirmed. It's a mucolipidosis, not mucopolysaccharidosis. Okay. Mucolipidosis type 1, it's called sialidosis.
Yes, sir. So that is difficult case, sir, first. And many times pancytopenia is because of marrow infiltration or because of massive splenomegaly leading to hypersplenism. So these type of patients, they need bone marrow transplant, so that we have to work up. But saying bone marrow transplant, it's not so easy. It costs money, you have to do donor workup, you have to motivate the relatives. That is very important. So, and personally as a hematologist, even if I do bone marrow transplant, I have done 69 BMTs, but doing BMT for a storage disease, I have limited experience or no experience at my center. So what I do, I send to some institutes where there may be some clinical trials going on, because must be patient is poor.
No, we have searched the literature.
Yes, sir.
We cannot get any association with the sialoidosis and this bone marrow suppression. We have searched a lot.
Yes, sir. Splenomegaly is there?
Yeah, massive splenomegaly, gargoyle faces. So initially we thought it can be a case of this Harlot disease. But after that, it came out to be a case of this thing, mucolipidosis type 1, or it's called sialoidosis. Yes, so the patient is still admitted in our unit.
Yes, sir. So massive splenomegaly may be possibly pancytopenia is because of hypersplenism. Yes, so even I will have to review that what is the current treatment algorithm for this particular disease. So maybe I will review and I will update you. That's all. Thank you, sir. Thank you.
Thank you, sir. This case-based presentation of anemia, thrombocytopenia is very helpful for the PGTs particularly. They'll, I think, remember your take-home messages for a long time, very useful, all of them.
Thank you, sir.
Thank you, sir.
Thank you, sir, for such an enlightening session. Now, I would like to request Professor Dr. Swapan Ray, sir, and Professor Dr. Banik Chaudhary, sir, to felicitate our speaker. I would request Dr. Avinash, sir, to please come forward for felicitation. Now, I request our speaker, Dr. Avinash, sir, to please felicitate our chairpersons. Thank you.
अशोक सर ना अशोक सर बबई सर
Good afternoon, everyone. After this enthralling session for 2 days, now it's time for felicitation of our judges of paper presentation. So I would request Dr. Ranveer Pal sir to come on dais for felicitation. I would request Dr. Anjani Kaushal sir to come on stage for felicitation of our first judge, Dr. Ranveer Pal sir. Thank you, sir. Now it's time for felicitation of our second judge for poster presentation, Professor Dr. Barnik Chaudhary, sir. Please, sir, please come on the dais. I would request Dr. Rohan, sir, to come on stage for the felicitation of our second judge for paper presentation. Thank you, sir. For the past 2 days, we had extensive sessions of paper and poster presentation by many students. So finally, it's time to announce the winners for paper and poster presentation. That is the first, second, and third prize. So first, it will begin with the award for the winners of the paper presentation. In the category of poster presentation, the third prize has jointly been won by 2 candidates. The names of those are Dr. Abhishek Kumar, MGM Medical College, Department of Microbiology. Please come on dais. And Dr. Suman Kumari from Lord Buddha Kosi Medical College, Department of Pathology. I would request Dr. Ranveer Pal sir to come on dais for giving away the award of the for the poster presentation. Dr. Suman Kumari from Lord Buddha Koshi Medical College. Anyone from Lord Buddha Kosi Medical College, Saharsa? Thank you, sir. Now it's time for the second prize, and it goes to Dr. Gitanjali Chaudhary, Department of Pathology, MGM Medical College. I would request Dr. Tapan Mukherjee, sir. Sir. I would request Dr. Tapan Mukherjee, sir, to come on dais to give away this prize. Thank you, sir. Now it's time for the first prize in the poster presentation category. I would request Professor Dr. Asitavo Dev Roy, sir, HOD and Vice Principal, Department of Pathology, to come on stage to give away this award. And the first prize in this category goes to Dr. Amod Bajpayee, Department of Ophthalmology. From our college, from MGM Medical College. After the poster presentation category, now it's time for the 3 awards in the category of paper presentation. I would for giving away the 3rd prize, I would request Dr. Nupur ma'am to come on stage. The 3rd prize in paper presentation goes to Dr. Rashika Raj, Department of Pathology, MGM Medical College. Now it's time for the 2nd prize in the category of paper presentation. I request Dr. Ranbir Pal sir to come on dais to give away this prize. The 2nd prize in this category of paper presentation goes to Dr. Nilanjana Chanda from Calcutta National Medical College, Department of Microbiology. Thank you, sir. Now it's time for the ultimate one, the first prize in the category of paper presentation. I would request Dr. Swapan Ray sir to come on stage for distribution of this prize. And the winner of this first prize in the category of paper presentation goes to Dr. Pushkar Prabhat from GNMC Betia, Department of Microbiology. आ जाओ। Thank you, sir, and congratulations to all the candidates who have won this award in paper and poster presentation. By this, we mark the end of this morning session. Next, we shall proceed for lunch, and after that, we would meet for the session on workshop and a session by Dr. Avinash, sir, for meditation.
After lunch, I would request you all to come back to this hall again for 10 minutes of heartfulness session by Dr. Avinash Singh, as Dr. Avinash has already mentioned. And after that, we'll proceed for the workshop on urine digital microscopy, and that is scheduled in our central laboratory section in the hospital building. Okay, thank you.
Should we start? So good afternoon. Good afternoon, everyone. Good afternoon. Good afternoon. ठीक है. So आप लोग आगे आ जाइए. Hardly 10 minutes it will take, 8 to 10 minutes. So you all are successful. You all are accomplished. Na? So you all are academic, educated. ये आवाज ऐसा होते रहता था क्या? आवाज? आप लोग बैठ जाइए जस्ट 5 मिनट के लिए. सो आई डू प्रैक्टिस हार्टफुलनेस मेडिटेशन. हार्टफुलनेस मेडिटेशन एक ध्यान सिखाने की संस्थान है. लास्ट 16-17 ईयर्स से ध्यान करते हैं. सुबह में हाफ एन आवर, कभी 10 मिनट, 5 मिनट. तो यह एक संस्थान है, हार्टफुलनेस संस्थान. जैसे आप लोग जानते होंगे अबाउट ब्रह्म कुमारीज, आर्ट ऑफ लिविंग ना, मुंगेर योगा, सो मेनी थिंग्स आर देयर. So just like that there is an institute called Heartfulness Institute. वो ध्यान सिखाती है. And I am a practitioner of that system. तो एक बहुत बड़ा सिस्टम है, उसको हम प्रैक्टिस करते हैं. इसमें ऐसा कुछ नहीं है कि हम बहुत बड़े योगी हो गए, संत हो गए, चाहे इनलाइटेंड है, ऐसा नहीं है. So as a doctor in last 16-17 years I practiced it and I have felt some changes, some inner changes. So I thought that if I am coming for scientific meeting and if suppose organizers allow, we can share. इसमें important नहीं है कि यहाँ जो 20 लोग बैठे हैं सबको फ़ायदा होगा या अच्छा लगेगा. Even if my type 1 person is there, may benefit, so that is worth sharing. Okay? तो मैं शुरू करूँगा अपने जर्नी से. जैसे I am from a very humble family, farmers family. तो अभाव था. तो घर में सब लोग कहते थे कि पढ़ोगे लिखोगे तो सुख आएंगे. सो बच्चा बड़ा हुआ तो लगता था कि चलो खूब पढ़ते हैं. तो खूब पढ़े तो MBBS में आ गए. MBBS में आए तो पहले बहुत सेलिब्रेशन हुआ घर में, लगा कि सही में कुछ बड़ा चीज़ मिला है. जब मेडिकल कॉलेज, व्हेन यू आर इन मेडिकल कॉलेज, तो लगा कि भाई ये तो हमसे ज़्यादा दुखी लोग पहले से हैं वहाँ. 2nd ईयर, 3rd ईयर, 4th ईयर ना, दे वर डिप्रेस्ड कि भाई बहुत लंबा है, ये है वो है. तुमको लगा गजब है यार. देन आई स्टार्टेड आस्किंग पीपल कि वाई आई हैव सो मेनी थॉट्स. सो आई ट्राइड मुंगेर योगा फॉर 6 months एंड आई डिड इट फॉर 6 months. जब किया तो अच्छा लगा, बट आई लेफ्ट इट. somehow I could not continue it. Then I tried one system, Art of Living try किया. वो भी जब किया तो अच्छा लगा, but I could not continue it. ऐसे 2-3 systems को try किया. Then I went to Guwahati. गुवाहाटी में MD मेडिसिन करने गया 2006 में, और वहाँ हमारे CBSE के कुछ जूनियर्स थे, who were from Bihar. So I asked them कि भाई आप लोग कुछ करते हो ऐसा ध्यान, जो मन शांत रहे, ऐसा कुछ. Because that was a new place, लैंग्वेज नया था, लोग नए थे, और ओवर बर्डन, बहुत ज़्यादा काम होता था फर्स्ट ईयर MD मेडिसिन में. देन आई ज्वाइन दिस सिस्टम. सो इस सिस्टम में 3 दिन का ध्यान होता है विथ ट्रेनर. एंड द ब्यूटी ऑफ दिस सिस्टम इज़ दैट आई नेवर लेफ्ट इट. ऐसा नहीं हुआ कि मैंने छोड़ दिया. बिजी रहने से 4 महीने 6 महीने ध्यान नहीं हुआ, बट समहाउ आई सर्च इट अगेन कि भाई दिल्ली गए तो वहाँ किए, बिहार गए तो वहाँ कर रहे हैं. सो आई थॉट आई वुड शेयर कि कैसे करते हैं और क्या है. सो द पर्पस ऑफ मेडिटेशन इज़ टू कंट्रोल थॉट्स. ठीक है, यू ऑल आर स्टूडेंट्स, वी ऑल आर स्टूडेंट्स. सो वी फोकस ऑन स्टडी. कोई प्रेजेंटेशन होता है तो हम ध्यान देते हैं. तो हमारा मन थोड़ा शांत रहता है नॉर्मल लोगों से। फिर भी आई वुड जस्ट लाइक टू आस्क यू, एक बच्चा है, ए चाइल्ड ऑफ 4 months और 6 months हु इज हेल्दी, you can see the innocence, the love, the purity over their face. किसी को देखते हैं तो मुस्कुराते हैं। As we age, what happens कि हमारा मुंह लटकने लगता है, we become depressed, we become anxious. ऐसा क्या होता है? So there is some problem in thought control. Thought control में कहीं कुछ दिक्कत है। एंड लाइफ विल हैव चैलेंजेस। यू आर स्टूडेंट्स ना, कुछ दिन के बाद आपकी शादी होगी, बच्चे होंगे, तो चीज़ें ऐसे नहीं होंगी जैसे आप अभी सोच रहे हैं। हो सकता है आप सोच के कुछ लिए होंगे कि हम लैब बनाएंगे, इतना पैसा आएगा, लेकिन चीज़ें ऐसे नहीं होंगी। सो वी नीड टू लर्न सम आर्ट, एंड दिस इज़ फॉर ऑल हेल्दी ह्यूमन बीइंग। मेडिटेशन इज़ फॉर ऑल हेल्दी ह्यूमन बीइंग, नॉट फॉर पेशेंट्स, डिजीज्ड पर्सन। इट्स जस्ट लाइक वैक्सीनेशन, हाउ वी कैन रिमेन हेल्दी, how we can remain childlike, innocent, pure heart filled with love. And there is a source inside you which have huge potential, huge love, like sea. When you are connected to that source in your life, whatever challenges in outside will come will not affect you. So we all should learn, it's important. So what we do in this meditation? In this meditation, we should fix one place. हमारे घर में एक जगह फिक्स कर देना है, एक चेयर रख देना है जिस पर हम ध्यान करेंगे। We should fix one time. It's said that कि before sunrise if you do, that is the best time, but it's called Sahaj Marg. Means according to your lifestyle you decide. I am free at 12 noon for 10 minutes, I will do that, but do it 12 noon every time, every day. It's not changing times. कभी 7 बजे किया, कभी 12 बजे किया, कभी 4 बजे किया, नहीं। Because it will condition your subconscious. Pavlov's का experiment याद है ना? वैसे ही 12 बजे you will go into meditation wherever you are. So time, place, position. So we sit in सुखासन। जैसे अभी हम लोग बैठे हैं, हमारे शरीर में दर्द नहीं हो रहा है, आराम से हैं, तो ऐसे बैठ के ध्यान करेंगे। जूता पहने हुए ध्यान कर सकते हैं, कोई दिक्कत नहीं है। कौन कर सकता है? तो एनीवन हु इज़ 15 above। ये भाई साहब लोग हैं ना, ये लोग भी ध्यान कर सकते हैं, उसके लिए डॉक्टर होने की ज़रूरत नहीं है। 15 above कैन डू मेडिटेशन, एंड देर इज़ नो कंडीशन कि भाई हमको सिगरेट छोड़ना है, हमको नॉनवेज छोड़ना है, हमको अल्कोहल नहीं लेना है। यू स्टार्ट डूइंग इट, एंड ओवर टाइम यू विल फील दैट वाट एवर इज़ गुड फॉर योर फिजिक, फॉर योर इमोशन, फॉर योर मेंटल वेल-बीइंग, you will continue doing it, and whatever is not good, the craving for that will drop off. I was a huge non-vegetarian. जब कभी CME में जाते थे नॉन-वेज खाने का एक रहता था, खाएंगे, घर में बनता नहीं था, बट ग्रेजुअली आई लेफ्ट द क्रेविंग। मेरा दोस्त सामने उसी प्लेट में खाएगा, हमको कोई दिक्कत नहीं है, बट आई लेफ्ट दैट क्रेविंग। आई एम नॉट सेइंग कि नॉन-वेज नॉट गुड, नॉट बैड, but I felt that for my spiritual development, for my physical health, it's not good. So just like that, if you smoke, no problem, you continue smoking, but you do meditation, and whatever is good will happen. Okay? So इसमें हम लोग क्या करते हैं? बैठते हैं, आराम से रिलैक्स होते हैं, आंख बंद करते हैं, and we start with a thought. हम एक विचार से शुरू करते हैं। विचार क्या होता है? कि The source of divine light is in my heart, which is attracting me inward. आँख बंद करके हम सोचते हैं कि हमारे हृदय में ईश्वरीय प्रकाश है जो हमें अपनी ओर आकर्षित कर रहा है। सिंपल शब्दों में हम सब लोग जानते हैं ना, सब मनुष्य में ईश्वर होता है, कहता है लोग ना, या अल्लाह होता है, या नूर इलाही होता है, जो भी है। सो वी जस्ट रिमाइंड विथ क्लोज्ड आई कि जो भी हमारे अंदर हायर पावर है इज एट्रैक्टिंग मी इनवर्ड, और हम बैठ जाते हैं। We don't repeat this, just one thought. Just like जैसे बल्ब जलाना हो इस रूम में, तो हम बार बार स्विच को तो ऑन नहीं करेंगे, हायर पावर वेट कर रहा है, जस्ट हमको रिमाइंड करना है कि ही इज अट्रैक्टिंग मी इनवर्ड। व्हेन यू क्लोज योर आइज यू विल हैव थॉट्स, इनॉर्मस थॉट्स, अननेसेसरी थॉट्स, कि अभी वर्कशॉप में क्या होगा, ये कौन आदमी बोल रहा है, क्या बोल रहा है, समय बर्बाद कर रहा है। सो वी हैव टू इग्नोर अदर थॉट्स विच कम्स, वी डोंट हैव टू इंटरटेन देम। So when you do meditation for 10 minutes, 15 minutes, at the end of meditation, you will feel something. So in this meditation, we start from thinking to feeling. We go from mind to heart. Okay? So you can give a try, and even without belief, without interest, you can sit for 5 minutes. And if you have interest, you can even download Heart's app, and you can see how we should start meditation. You can take online sittings and you can continue it doing. There are many good books you can take. You can listen to YouTube talks. But at age of around 49-50, I feel that मेरे जीवन में घटने वाली जितनी भी घटनाएं होती हैं, जैसे MBBS करना होता है, शादी होती है, बच्चे होते हैं, तो उसमें सबसे इम्पोर्टेंट घटना इस हार्टफुलनेस ध्यान से जुड़ना है. हमको ऐसा महसूस हुआ. तो हमको लगा कि मेरे कोई भाई बहन जो होंगे, हो सकता है उनकी ज़रूरत हो, तो दे कैन कनेक्ट टू दिस पर्टिकुलर सिस्टम. और ज़रूरी नहीं कि हार्टफुलनेस से ही आप किसी ब्रह्म कुमारी, आर्ट ऑफ लिविंग, किसी से भी हो, बट इन लाइफ वी नीड सम सपोर्ट सिस्टम विच कैन गाइड अस. और ये मेडिटेशन आपको किसी को गुरु नहीं बनाएगा कि बाबा बन गए हैं, आप उनके पीछे पीछे घूम रहे हैं, ऐसा नहीं है. यू विल बिकम योर गुरु. Your higher power will guide you. Whatever challenges will happen, that inner guide will always be with you. So you will take all challenges in life, just like childlike innocence, love. When you do work with that innocence, your work will be different. You will be different. So, okay, so we should try. Start करते हैं. Light off कर दें. आप लोग भी आके बैठ जाओ. So हम कुछ कहेंगे गाइडेड, उसको फॉलो करना है. और इतने सारे लोग हैं तो किसी का फ़ोन बज सकता है, तो उससे इरिटेट नहीं होना है, बजने दीजिए. ट्राई टू स्विच ऑफ और एयर फ्लाइट मोड कर दीजिए उसको. एंड व्हेन आई विल से दैट्स ऑल, ओनली देन ओपन योर आइज़. और प्लीज़ बात नहीं कीजिएगा. किसी को मन नहीं हो, इंटरेस्ट नहीं हो, दे कैन गो आउट. बीच में भी चले जा सकते हैं, लेकिन जो 1-2 लोग ध्यान कर रहे होंगे उनको डिस्टर्ब नहीं करना है इस पेन को. ठीक है, पंखा बंद करना है. हाँ, so close your eyes. अपने आँख को धीरे से बंद कर लें. 2 बार लंबी और गहरी श्वास लें और धीरे धीरे श्वास छोड़ते हुए अपने आप को शांत एवं शिथिल बनाएं. अब एक विचार लें कि धरती माँ से एक रोग हरने वाली ऊर्जा हमारे शरीर में पैरों से होते हुए प्रवेश कर रही है. अपने पैर के अंगूठों को हिलाएं और उन्हें शांत एवं शिथिल करें. आपका सोल, एंकल, काफ, नी, थाई, हिप्स, दोनों पैरों की एक एक मांसपेशियां शांत, शिथिल, तनाव रहित हो गई हैं. दोनों पैरों में जो भी थकावट या पेन था वह बाहर चला गया है. धीरे धीरे मदर अर्थ से आने वाली यह डिवाइन एनर्जी हमारे कमर, पीठ, पेट एवं छाती की मांसपेशियों को शांत एवं शिथिल बना रही है. हमारे कमर में जो पेन या स्टिफनेस था वह पिघल गया है. धीरे धीरे मदर अर्थ से आने वाली यह डिवाइन एनर्जी हमारे दोनों कंधों में प्रवेश कर रही है। कल्पना कीजिए जैसे दोनों कंधे पिघल रहे हों। अब गर्दन के पीछे की मांसपेशियां रिलैक्स हो गई हैं। मस्तिष्क की मांसपेशियां तनाव रहित हो गई हैं। अपने चेहरे पर एक हल्की मुस्कुराहट लाएं। आपका फेशियल मसल्स, आपका फोरहेड, आईज, नोज, ईयर, टंग, चिक्स, ठुड्डी सारे शांत, शिथिल, तनाव रहित हो गए हैं। मदर अर्थ से आने वाली यह डिवाइन एनर्जी हमारे पूरे शरीर में प्रवाहित हो रही है और हमारा शरीर रिलैक्स हो गया है। अब धीरे से अपना ध्यान अपने हार्ट की तरफ ले जाएं और एक विचार लें कि द सोर्स ऑफ डिवाइन लाइट इज इन माय हार्ट which is attracting me inward. Please start meditation. अपने आँख को बंद रखते हुए you can note your condition and then gradually open your eyes. How you are feeling. Thank you everyone. Can we have lights on? So sometimes closing eye for 2 minutes, it's difficult, most difficult work. But we have to learn the art of meditation. So regular, we have to practice. And किसी को कुछ शेयर करना है, कुछ लगा हुआ हो पाया, अच्छा लगा, चलो, वेरी गुड. So it's very important. A good meditation, the contentment and satisfaction that you will have, उसकी तुलना बाहरी दुनिया के किसी अचीवमेंट से नहीं की जा सकती है. So we have to try to experience क्या होता है, रेगुलर करना है. It's just like sea. समंदर में सरफेस पे बहुत ज्वार भाटा आता है. It's like our life, जिसमें लोग हमको इरिटेट करते हैं, बोलते हैं, प्रॉब्लम देते हैं, बच्चा नहीं सुनता है, पत्नी नहीं सुनती है, पति नहीं सुनता है. It's like surface water. In meditation or a meditative mind, it can go deep. मान लो 500 मीटर नीचे चला गया, ऊपर का जो वेव्स है वो अफेक्ट नहीं करेगा. आपके परिवार में कोई आदमी होगा जो अफेक्टेड नहीं होता है, और कोई होगा जो ऐसे ही इरिटेटेड रहते हैं, उनका वाईफाई ऑलवेज ऑन रहता है, हर तरह का प्रॉब्लम हम लोग खींचते रहते हैं. और सपोज ए पर्सन हु इज मेडिटेटिव एंड ही इज एट द बॉटम ऑफ द सी, सो इवन सुनामी कम्स, ही विल नॉट बी अफेक्टेड. सो वी ऑल कैन लर्न. And it's free, we can learn. So HeartSap you can download, you can see features, you can learn. Thank you everyone.
Yeah.